Okay, members, the time is now 5:39. Good evening. Today is June 30, 2021, and it is 5:39 p.m. As a quorum of the board is in attendance, I would like to call to order the meeting of the Central Health Board of Managers. The first item of business is public communication. Members of the public who wish to make comment during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 3:30 p.m. today. Yvonne, did anyone register to make comments?
Yes, Madam Chair, we have 3 people who registered to make comments.
Okay.
I will now read the guidelines for public communication. To be recognized to speak, you must request a speaking slot using our public communication online registration form or by leaving a voicemail 90 minutes prior to the start of the meeting. Individuals are asked their preferred language as they register to speak, and both the online form and voicemail greeting are in English and in Spanish. When called upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. To ensure the efficiency of the meeting, once we let speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments before they are muted. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. And with that, I'm gonna go ahead and call on the first speaker. And the first speaker is Casey Hansen, and Casey Hansen is with the UT, with the Dell Medical School at UT. Casey?
Casey, you're on mute.
Thank you. Good evening, Board of Managers. My name is Casey Hansen, and my comments pertain to item number 2 on today's agenda regarding Dell Medical School. I'm a program manager in the Division of Community Engagement and Health Equity in the Department of Population Health at UT Austin's Dell Medical School. Our mission is to leverage collaborations with community members, organizations, government entities, businesses, policymakers, and the greater UT community to tackle social determinants of health, promote health equity and quality of life, and improve health outcomes. I'm here today to provide public comment about an initiative called the Central Texas Check-In, which we launched in 2020 with more than 50 community partners. For the last several years, we've worked with community members and community health workers to create a household level assessment that, number 1, builds trust while we assess underrepresented communities, and secondly, measures social determinants to identify what specific drivers at the household level are preventing optimal health. So we tailor our assessments based on community feedback to only ask questions that yield a resource connection. The pandemic prevented us from doing our scheduled research, of course, physically in people's homes, but our household work led to a collaboration with the City of Austin. The Central Texas Check-In was a needs assessment focusing on about 7 to 10 priority populations, and I'll just name a few: those who were 55 and up, those in the Asian population, African-American population, Indigenous folks, Latinx community, folks with chronic diseases, pregnant women, and residents in the Eastern Crescent. When needs were identified by community members, we pointed those families to resources using vetted lists from, let's say, a city council member or other community resources like 211, Connect ATX, or Aunt Bertha. In order to complete the Central Texas Check-In and to ensure that those hardest to reach and fastest growing populations in our city were included and connected to services, we engaged our community partners. They helped us push the survey out to the priority populations via email, text, and post on social media. They also helped us connect with families whom some lacked experience connecting to public services at all. For example, one partner allowed for us to call people because they knew that they didn't have access to the electronic survey. And the majority of those folks were in that 65 and up population. So with the help of our community partners, we reached over 750 households. These partners were our virtual arms and tentacles into the community They are a part of our health ecosystem, as we respect the work that they do in the community and the relationships that they already have with the communities they serve. We do not take our partnerships for granted. And DelMed is part of, this Austin community, but we're the new kids on the block. We bring resources and expertise, but we highly value the community organizations that have allowed for us to work alongside them. I'll stop there, and thank you for the opportunity to provide comment.
Thank you.
Thank you, Ms. Hansen. The next speaker is Dr. Stephanie Morgan with the UT School of Nursing.
Hi, thank you guys for allowing me to speak. I wanted to give an update on our vaccination process overall. This is the first time I'm speaking at this meeting in this forum about this. So, clearly our hub process, the hub and spoke distribution model is what we're doing, which I know many are. And most recently, we have shifted from the large hub concept at Gregory Gym at the end of May into more of a mobile vaccination operations, as many people have, to really reach into the pockets of the community that are the most hit. And then of course, people that have significant limitations with accessing, either due to fear, either physical or psychological challenges. So our current process at UT is kind of twofold. Our hub has shrunk down, and we are now providing our vaccines, and it's primarily Pfizer, out of our health transformation building. And those appointments can be appointments or walk-in, and it's Monday through Friday, 9 to 5. And in addition to that, we have at the end of the day 2 programs that are mobile related. One is called VAMOS, Vaccine Administration Mobile Operations, which actually started in the beginning of March. And then another program called Vax Now, which is Vaccine No Waste, which takes vaccines at the end of our hub and takes them into the community to homebound people. And that can be anywhere from 0 up to 20 people, which we go to their homes and administer. And our VAMOS program, both of them are really full-fledged now because all the resources from Gregory Gym, many of them moved to the mobile setting. And we have made 44 visits in the VAMOS alone, which is basically 22 sites where we have at least visited twice. Although we do have access to Pfizer, we have access to Moderna through the School of Nursing's clinics, and we do have access to Johnson & Johnson. So we are really trying to tailor it not only to location where there's greatest need, but also there are people now asking for choice and wanting to meet them where they are and what they feel is safe for them in order to get more people vaccinated. So of our locations that we visited, 14 of these locations, those are initial visits, have been east of I-35. Of course, we also participate, as many of the folks here on this call do, with the Vaccine Planning Coalition with Austin Public Health and Travis County. So we can really continue to zoom in and focus on those zip codes that still need to have the greatest effort. And some of the partners we're working with clearly are some of the ones in the community that many of you guys are, Meals on Wheels. We are working with the Austin ISD, Where We Thrive, some unhoused camps, and then the Andy Roddick Foundation. And people are reaching out to us to contact us, either website or phone or email, and we will follow up with them to make sure that we can get an event where they need it. In addition to us being proactive to actually look at zip codes that need a regular visit or what we call a static placement, such as out in the Del Valle area with some of the churches we've partnered with out in there to have kind of a weekly presence in that community. So with that being said, that's kind of the overview of kind of what we're doing at UT, and then I will leave it to you guys if you have any questions for me.
Thank you. Appreciate it.
Thank you, Dr. Morgan. Our last speaker for public communication is Juan Garcia, and he is with UT Austin. Mr. Garcia.
Good afternoon, everyone. My name is Juan Garcia. I'm a rising 4th-year student at UT Austin. And today I kind of wanted to talk a little bit about the support and impact that Dell Medical School has had on my pre-medical journey thus far. So I would like to start off by talking about the See Del Med Tours program, which is basically a tours program where I have the chance to present to the general public, to undergraduate students, as well as to some high school groups. And having the opportunity to do this has allowed me to develop my my communication skills, my presentation skills, and also some of my leadership skills, which are important for any future aspiring physician to develop. I also had the opportunity to work with the health science summer camps and the year-long program, which are basically pipeline programs that are aimed at low-income ethnic minority students in the Austin area in an effort to expose them to the health sciences at an early stage in their education in an effort to promote them to aspire to get into higher education and potentially in the future diversify our healthcare workforce. The medical school has also supported a lot of undergraduate students by first sponsoring the first official undergraduate organization at UT Austin, the Dell Medical School Pre-Health and Diversity Scholars. And they've also now recently become one of the 11 schools that participates in the JAMP program. So myself as a JAMP student, I now have the opportunity to apply to Dell and potentially match. I also have the opportunity to attend an internship at Dell where they would expose us to the curriculum and kind of the culture and the environment that they have to offer to their students. Last and not least, I would also like to talk about my experience with the Factor Health Sunshine Cause. So the Sunshine Cause program was basically a program aimed at discovering some of the impacts that the COVID-19 pandemic had on the elderly community. So myself as a volunteer, I was responsible to call around 6 to 8 individuals that participated on the Meals on Wheels program and have a brief conversation with them, talk about what they did yesterday, talk about their life, talk about any worries or concerns that they may have, such as inaccessibility to food or inaccessibility to their medicine. And having this experiences have really impacted me because it made me realize that even the smallest actions, such as a simple phone call, can have a lasting impact on someone. So developing these personal connections with these individuals allowed me to impact their mental health and their overall physical health without actually having a medical degree, which was just something amazing for me to experience. And for that, I'm grateful and thankful for everything that Dell Medical School has supported me with and has provided me with. And I hope to one day be able to be a part of this revolution and be a part of this change in order to create a more equitable healthcare system for everyone, no matter what ethnicity, no matter what language you may speak, no matter what your financial situation may be. Thank you.
Thank you, Juan, for sharing with us so eloquently, and we deeply appreciate your community service, and thank you for all that you have done and I'm sure will do.
Thank you so much.
Thank you, Juan. This concludes the public communication portion of the meeting, Madam Chair. Thank you.
Thank you so much, Yvonne. We will now proceed to the consent agenda. Managers, the item to accept the grant award, which is C4, will have a related contract that will be before the board most likely in August. So please hold any questions about the contract until it's been fully evaluated by the staff and is ready for presentation in August. The consent agenda, we are now proceeding to C1. Approve the minutes of the Central Health Board of Managers May 26, 2021 regular meeting, May 24th and June 9th, 2021 board retreats, and May 26, 2021 special call meeting. C2, receive the quarterly investment report and ratify Central Health investments for May 2021. C3, accept the preliminary May 2021 financial statements for Central Health and the Community Care Collaborative, including fiscal and related operational updates for community care health centers and Sendero Health Plans, Inc. C4, accept a grant award from the Episcopal Health Foundation in an amount not to exceed $600,000 for the purpose of funding a community healthcare needs assessment for the low-income population in Travis County, extensive community engagement, and the development of a proposed equity-focused strategic service delivery plan. C5, approve the appointment of Betty DeLargy to the Board of Directors of Sendero Health Plans, Inc.
Madam Chair?
Yes, Manager Bell.
I move that the board approve consent agenda items C1 through C5.
Okay, there's a motion. Is there a second? Manager Valadez?
No, I wanted to pull items C3 and C4 for regular discussion.
C3 and
C4.
Okay, so managers C3 and C4 have been pulled. Manager Bell, do you have a motion?
I move that the board approve consent agenda items C1, C2, and C5.
There's a motion. Is there a second?
I'll second.
Okay, was that Manager Musaitov?
Yes.
Yes, who's second? All in favor say aye. Aye. Opposed, same sign. Any abstaining? Thank you, managers. That passes. We will now proceed to the regular agenda. Managers, item 7 will not be discussed this evening as there's nothing to report on that item. The item was, and I'm reading the item that was number 7, discuss and take appropriate action on Central Health owned or occupied real property and potential property for acquisition, lease, or development in Travis County, including next steps in the redevelopment of the Central Health downtown campus, administrative offices of Central Health and its enterprise partners, and new developments in Eastern Travis County. Mr. Giesland, I know we have someone here for agenda item 1, and also Mr. Duncan. How do we proceed with that and the items that were pulled?
You can do them now, or you can do them later in the agenda if you think it's going to take a lot of time, because I do know we have some of the UT presenters waiting as well. So
okay, I think we will take them probably at the end of the agenda, because we have people who are here to present. Okay, so we will move to regular agenda item number 1, discuss and take appropriate action to reach agreement on board shared commitments in support of a diverse and inclusive culture and collaborative meeting process to achieve health equity. Members, you know that this is a follow-up from sessions 2 and 3 in our 3-part series of our board retreat. And I thank you all for your participation. You have, I know, read what we have before us that we had talked about making a commitment to. Dr. Martha Ramos Duffer will briefly do a high-level presentation since you've had it before you. And then I would say if there are any questions for her, and then we can move on with this item. Dr. Duffer.
Thank you so much, Manager Greenberg. And it is wonderful to see all of you board managers again. And we have reached an exciting point in our work. And so I know you have a long agenda ahead of you this evening. So this can be a very short and sweet part where we really just come together in agreement for all of the work that we did in the trainings. So what you have in front of you are the shared commitments that we discussed in our trainings. And I know how much all of you are really committed to moving forward the efforts to achieve equity that Juan Garcia so inspiringly talked about moments ago. And so to that end, we discussed a number of skill sets and approaches to facilitate having efficient and thoughtful board meetings that really help y'all use your time, be good stewards of the time resource that you have, and ensure that everybody is able to meaningfully contribute and that the decisions benefit equitably from everyone's contributions. So the scope of these agreements are the highlights of those skill sets and approaches that we discussed. And so these are the agreements to move forward, to work together in a way that can further support you in being successful in your aims. And I am here. So our hope is that as we all agreed in the training, that you will each feel prepared to sign this evening to move forward. And again, in our training, we discussed this. Everybody was excited about signing it and moving forward. And so this is me summarizing all of those highlights and putting it into one document. But I did want to be here with you this evening, to celebrate this moment of having culminated this work and being well positioned to bring the work into action steps, and then to answer any questions you may have to ensure that we're able to move forward with y'all now practicing these agreements, commitments.
Thank you, Dr.
Any
Duffer.
questions?
Thank you, Dr. Duffer, for the... If people are not speaking, maybe they could meet. Thank you, Dr. Duffer, for the excellent training and for that summary, for providing us with the commitments in the document that we spoke of, and the attachments, members. You saw the reference attachments from our training. So are there any questions? Manager Valadez?
Yes. Hola.
Hola.
How are you doing again? I have some just preliminary or some fundamental questions with respect to your use of the term anti-racist or racist. I just want to make sure that we as a board fully understand that we're talking about language, cultures, blah, blah, blah. Anything that could cause a group, a population to be discriminated against because they've been marginalized, they've been historically excluded from the processes, and are basically endangered. They're an endangered community. So I wanted to make sure that when we do this and when we pass this, that we have some kind of a preface statement, if it's at all possible to do.
Manager Valadez, I think that there's language in there really that addresses that, because it speaks to races, ethnicities, language, or any other characteristics. It speaks to.
Well, let me ask Dr. Ramos.
Okay.
I've read this, and
Dr. Duffer, can you respond to that?
Well, no, let me finish, please.
Okay.
If you don't mind, I'd like to finish my issues. So in having, because this to me is a communication document, in having communication, open communication, we have to allow for discussion. And that means we need to have a statement that there will be discussion allowed at all our meetings, that we will follow Robert's Rules of Order that says that we have to have discussion at all meetings. Otherwise, how can we inform ourselves to make a better decision, or the best decision for our population, and to fulfill our fiduciary responsibility? In addition to that, that also means that we are receiving the information, the documents, the backup data that we need to have in place to review on a timely basis prior to the meetings, not the minute of the meeting.
Manager Valdez, I need to interject here that we use Robert's Rules of Orders, and I think that we need to keep that separate from this commitment document.
Well,
any discussion of backup to our I would request
to our agendas
that we discuss that separately, because that really is separate. We use Robert's Rules, and we certainly want everybody informed, but I would ask that anything dealing with agendas really that's separate.
Well, then
and I can respond, Manager Valadez, if you'd like. I can respond to your first
I appreciate
question.
it, Martha, because one of the things that this forces me to do is then ask for a point of clarification or point of information, or whatever a point I need to make of our legal counsel, to make sure that they can cite to me where it says that in following Robert's Rules of Order, that there has to be discussion.
Okay, let me see, Manager Valdez, if I can split your question, okay? Dr. Duffer's going to respond to the first portion, and David Duncan, could you respond to the second portion?
So I'll quickly respond to the question about what we're including as we consider oppression. And yes, as Manager Greenberg was saying, we included ethnicities, races, skin color, multiple characteristics that people have been historically, systemically disadvantaged based upon. So that is included. And for the point of discussion is related to this document, what this document is doing is talking about how to approach discussion in a way that is consistent with generative leadership, generative dialogue, and generative conflict to support the board in being effective in its aims.
So just very quickly, you and I have spoken, and you kind of understand where I'm coming from when I say these things. You know, my initial objective right now is to apologize because Central Health has not achieved equity with all our populations. We have not, in here, I'm sorry, maybe I missed it where it said that we also take legal status into account. And so for that the first thing we have to do is apologize for not having achieved it. And what we are going to do as a board of managers is work with staff to ensure we implement appropriate policies and make appropriate decisions so that those disparities can be eliminated, so that we can eliminate the privilege component, the entitled component, and so that there are no more marginalized populations within our community.
Absolutely. And one of the items in there speaks to being advantaged. There's another one that speaks to privilege. So are you able to sign the commitments, Manager Valadez?
Oh, I have no problems in signing the commitments. When I spoke to you on, that shouldn't be a surprise. When I spoke to you on Monday,
I'm not surprised.
I told you specifically the thing that stood out about your 6 hours of training was the last option, and that was the suggestion of developing some kind of a document. But for purposes of myself and serving as a board member to our public and to our marginalized populations whose needs have not been taken care of, I believe that we have to premise our statements in acknowledging the fact that we have not achieved our goal, and that what we are trying to do is create an open, transparent opportunity to work with our patients, with the population, to make sure we accomplish this.
Thank you for so eloquently summarizing the goal. Thank you. We really, really appreciate that. David Duncan, could you answer the Robert's Rules of Order question?
Could I clarify the question? Is the question whether debate can be limited in board meetings?
No, the question was, where does it state that we operate via Robert's Rules of Order as a board of Central Health?
It's in our bylaws.
It's in our bylaws. Thank you. All right.
No, excuse me, sir. David Duncan, one more time. My question to you is, as our legal counsel, where in Robert's Rules of Order does it state that we have to have a conversation in order to be able to conduct business?
Okay, David.
If we're not allowed
to, Manager Valdez.
I'm asking, Madam Chair, excuse me, can I please ask?
I think we understand the question. David, can you respond to that?
So if I gather the question correctly, the question is, what is deliberation under Robert's Rules, and how does Robert's Rules speak to that? Robert's Rules speaks in terms of how a body functions and how it deliberates and how it gets to decisions.
That's right.
And it doesn't say, all it says is the chair has a certain role, the members have a certain role, the members have to ask to be recognized, the chair recognizes them. If you get very formalistic, and I'm sure you've been to the legislature, I'm sure you've watched the legislature, the chair of a committee or the chair, the standing chair of the House of the Senate, when someone approaches the microphone, the members recognize for what purpose. So they get very formalistic about it in some bodies and ask, what are you here to talk about? We've never gotten that formal, but the very, basically what you're talking about is the very framework of Robert's Rules. It's not, I can't pull it off the shelf and find you a word that says that, but the very flow of it is members are members and are allowed to speak on the topic that is before the body. So that there are boundaries on it. And that's kind of what I was getting to, is I thought you were talking about the boundaries, and there are ways of putting boundaries on it, either by the body or, keep in mind the Open Meetings Act affects this too. You can't just talk about anything. So every once in a while you'll see me jump in and go, oh, we're getting a little off the topic here. Let's remember what the posting says. So yes, open discussion, but within limits. So I hope that answered your question.
I appreciate that, David, because that was the clarification that I needed to have, that the spirit of Robert's Rules allows for and calls for discussion. Yes, in order for one to be able to get to a point where they have discerned the issues, understood the data, and are ready to make an informed decision. Thank you. I just wanted to clarify. I want to thank you, David.
Let me bring us back, because our goal is to make sure that all managers are able to sign these commitments this evening. So are there any questions that would help us move toward that goal?
One last
I think other people had their hands up. I
Zuniga
saw
had her hand
Manager
up.
Musaitif and Manager Zuniga.
Yes, Manager Zuniga, then Manager Musaitif.
I'm ready to sign. I think that the format's great, and that that we respect each other, and that we use appropriate language is what we're trying to move forward with. And I think that is the point of what this was meeting with. And it was great to meet with Martha, and I look forward to furthering our anti-racist agenda.
Thank you, Manager Musaitif.
Thank you. Thank you, Martha, for your training. I also concur with Manager Zuniga, what she stated. And I think we as a board need to set an example for our staff and community and enterprise. And it starts with us. And we ought to respect everyone and treat everyone with dignity and respect, regardless of who they are. We may have difference of opinions, and we need to respect that. I'm ready to sign this commitment, and I hope we will follow through. And thank you again.
Thank you. And thank you, Manager Zuniga and Manager Musaitif. I wholeheartedly agree. Is there anyone else? Manager Jones.
I just have a question related to Robert's rule, because in signing this, my understanding is implicit in it is that we're consistent. We're going to abide by those rules.
We have to in our bylaws.
Okay.
Our bylaws state that we operate under Robert's rules, so we must, yes.
Given that, and this is a question for Mr. Duncan, is there anywhere in there that we have the ability to limit, in terms of time frame, discussion?
Yes, that was one of the guardrails I was talking about that exists in Robert's rules. The body can impose limits on itself always.
Yes, yes, Robert's rules allows for that. Yes, sir.
And consistent with our discussion now, I think to be mindful of our right to present positions and understanding the equity and diversity, we also need to be mindful of and respectful of people's time. And so once points are made, we don't have to rehash them and rehash them and rehash them. So I just want us to embody that in our discussion as well.
Thank you, Manager Jones. And in fact, that is part of the commitments. When you read through them, that is specifically spoken to in the commitments that we're signing. Anyone else at this time? Manager Bell.
Martha, I just want to thank you so much for the opportunity that you've given us to look at the way that we conduct ourselves as we hopefully come together as a cohesive board and understand our differences, respect each other, including, as Manager Jones said, respecting our time. We give a lot of time, and everybody's time, including the citizens that are attending, is valuable. And so we need to make the best use of that. And finally, I commit to signing the commitment that has been drawn up. I think it outlines well how we should conduct ourselves now and into the future. Thanks.
Thank you, Manager Bell. Yes, the generative discussion, the deliberative dialogue, the collaboration and respect for all is so important. Anyone else at this time? Looking to see. Manager Valdez?
Yes, on item 9 and 10, it continues to refer to section 19 and 20, which doesn't exist, not in what I have.
I'm so sorry about that error. You're absolutely right that the first version that we sent out did have that error, and we have since sent out a corrected version that refers to the correct numbers.
I'm sorry, I didn't ever see a first version.
It was emailed out, a corrected.
Okay. This is the one I saw. And
I understand.
So are we going to correct that before we vote on it and take action?
We are discussing the corrected version, the latest one that was emailed out. So we don't need to correct that. We have all received it.
Well, the one I picked up today.
I understand it was after you picked up, the typos were caught and the corrected version was emailed out.
Okay.
The only difference is that those numbers are corrected to refer to the correct numbers now.
What? To reflect what? Because I don't have that.
I believe it's 7 and 8. So rather than saying,
that's all anybody needs to say. They don't need to reinforce that this was made after you picked it up. Okay, just 7 and 8, replace it. Thank you very much.
You are quite welcome. Anyone? Okay.
I make a motion that we adopt them.
Okay. So there is a motion. Is there a second? Motion by Manager Valdez, a second by Manager Bell. All those in favor say aye. Aye. Opposed, same sign. Any abstaining? Thank you, managers, for this really, really important discussion, for participating in the workshops. Dr. Duffer, thank you for your tremendous training. And I think that this gives us the framework that we need to move forward in a respectful and equitable manner for each other, for our staff, and for our community. And I thank everyone from the bottom of my heart. Really appreciate the hard work on everyone's part. Thank you so much. Right.
Gracias, Marta.
So we will now move on to agenda item number 2, receive an update from the University of Texas at Austin Dell Medical School on Central Health's financial investment and how it has contributed to fiscal year 2021 outcomes, supporting Central Health's mission of serving indigent residents of Travis County, and an update on the University of Texas at Austin Dell Medical School's future opportunities and challenges. Dr. Clay Johnson will be presenting. Dr. Johnson?
Yes. Sorry. Good to see everyone, and thank you very much for having me here this evening. It's a pleasure to be here. And again, I thank you all for the wonderful service that you provide to our community. We are so fortunate to have Central Health, and we're very fortunate to have your leadership in such a great commitment that you all make in providing this input. So I realize this needs to be a quick presentation. I do have 10 slides, but I'm going to go through them very, very rapidly. You have also materials that you have received from us that describe in detail the things that are in these slides. And I would encourage you to look for details on those because I won't have time to provide those unless we do so in the Q&A. So can you all see my screen? Yeah, okay. That tiresome question that's always asked on Zoom. So there were a number of ways that this was a remarkable year for Dell Medical School. I think most importantly has been in us all as a community having to respond to the COVID-19 pandemic. You can see and read about some of these specific things that we did. I think most importantly was the collective impact that we had as a community working with Central Health, Community Care, the hospital systems, Austin Public Health, and CATRAC and the other major entities to actually have a better outcome in Austin than any other city in Texas by far. You know, our incidence rates were substantially lower and our mortality rates were also substantially lower. And I do believe that that was related to the coordination that we were able to achieve across the city. The university played a big part in that, including the med school, but it was really about collective action and accountability at a very high level. And, you know, I'm thrilled that we're at this point. So you all know we did substantial amount of testing and vaccinating, and you heard from Stephanie Morgan about some of those programs. We also had substantial programs for the homeless, got philanthropic support to extend that. So had an incredible return rate and high rate of vaccination amongst the homeless, and never had an outbreak amongst the homeless, really because of aggressive protection. And that was with Community Care, you know, a very close partner in that work. And then we also had other important programs. I think Good Apple was one you've heard about before and can read about. I'm very proud that that was created by our medical students and fed a lot of families in the work that we did in the hospital. And that hospital work is pretty remarkable. If you look at Del Seton, we completely changed the care. Early on and throughout, about 80% of the folks in Del Seton were residents from East Austin. So it's really important to provide great care to those that were most affected by COVID. The outcomes there were substantially better, some of the best in the country, with case fatality rates substantially lower than the national average. We also are working closely with our partners, and as we always do. These programs continue to grow. So, lots of hours of work from our residents, a lot more residents now than we've had in the past as the programs grow. And we've added 21 new residency programs, and almost doubling of the number of residency programs that we have, residencies and fellowships. And that's going to bring more specialist care and general care into our community. Pediatrics in particular, a lot going on there, and just, everybody has access to that care. Thankfully, Medicaid does cover children. And so our programs are well accessed by those with Medicaid. In both heart disease and pediatric neurosciences, we have superb programs, and we're building out others as we speak. And then we are doing a lot in the mobile medical and mental health care work. Some of that has been supported by large gifts, doing that with community care and integral care. So we continue to work on new models of care for MAP patients. MAP patients are our priority. We always like to start there with our models. And so we've introduced the GI model. You all have heard about this before. We're thrilled with just how efficient that model is and how effective it's been at reducing weights. It's quite similar to what we did in musculoskeletal care a few years ago, but now applied to GI. This is done with Seton. These are folks that we hire, but they also contribute to this model. And it's also done with community care, where we're actually providing e-consultations directly into community care sites to reduce the need for people to come out and be referred and have to deal with all the transportation and other issues. And then directly in the community, we have a number of programs. As usual, these are unusual for med school to be doing this, but it's a key part of our mission, as you know. And we're proud to be expanding our community health worker programs. This is all, well, a little bit supported by our core funding from you all, but a lot of this comes from philanthropy. We're adding community health workers in a variety of settings to deal with social determinants of health predominantly that lead to a lot of the disparities that we see in outcomes for patients, particularly MAP patients and non-MAP patients with low or no income. And then in women's health, putting back on the street, we've been convening all these groups to try to improve women's health and access to cancer screening. That's now up and running. We're looking for additional philanthropy to get that going, but that's been a really nice group. We're a part of that. We hope to lead it. But again, it's about collective action. And then beyond the clinic, you heard already about the Sunshine Calls, really remarkable program. I mean, so easy, simple, cheap, huge impact, and targeting it in the populations that really need it. And now we have really solid data that shows that that works. And so that's, I think, really exciting. And other programs too that we're doing with Meals on Wheels. In the cancer prevention and control programs, I mean, we should all be really proud about how effective these programs have been. This is a collaboration between us and community care, and we have to acknowledge a very large grant that we've gotten from CPRIT that Mike Bignoni, our chair of internal medicine, was able to secure. So lots of additional screening. The program works. It's really simple for folks. It's free. It's a remarkable program. It includes follow-up endoscopy if they need it, colonoscopies if they need them. So looking ahead, So where are we in terms of budget? Where do the allocations go? And obviously every year we have the agreed upon procedures. It's too early for those at this point, so we haven't had a full year to review. That will happen, but last year's review went fine, as you all know. And you've already seen this, and hopefully have had an opportunity to look at it. I mean, I think bottom line is, you know, we've been responsive to invest in those things that are clearly aligned with Central Health's mission, and it's predominantly in clinical areas. I know there's a big issue about, well, who's funding what, and that is obviously complex, but you can see how this works its way through our departments. Many departments don't receive, even though they're providing substantial care to the MAP population, other populations don't receive, other poor populations don't receive any funds from Central Health because they're supported through philanthropy or other means. And so, you know, you can kind of see where things are going. So future opportunities, I wanted to just spend a little time on this. We do have successful clinical programs. We want to add more. I mean, to be able to get to more people, eliminate wait lists, provide a much better experience, address the inequities by making things more convenient, easier, and lower the cost in doing that on a per capita basis. We just got to keep doing that work. And we have to figure out how to do it. We need more physicians in the safety net environments so that kind of access isn't an issue. Our students are really motivated by that work in the community, and so we need, we want more and more of that to be happening. We have to address the prioritized public health issues, as you've heard, we already have, and need to accelerate that, and then support COVID as the pandemic hopefully recedes. Inequities are a critical issue for us, and critical issue for Texas. So, you know, that becomes front and center. You all know Joel Mullen, who's been wonderful at helping to make sure that our efforts in health equity reach beyond just the superficial or performative and really go deep into a variety of different areas. And then leverage community support to maximize these multiplicative investments. And there are many, many multiplicative investments. I mentioned a few, but there's a lot of philanthropy, a lot of grant money coming in that wouldn't be possible without the investment that you all are making. And then finally, just some future challenges. I think we need to move from a sickness system to a health system to actually care about the health of people and try to keep them out of our hospitals and even out of clinics. And I think we can do that together. You all also have that mission, but this is going to take real work to do it. We obviously have needs in the sick care part, so we can't rob one in order to pay for the other. So how are we going to balance these things, and when do we see the benefits of investing in health? That's work that we've already started to do together. I hope we can accelerate that work in the coming year. And then finally, and very importantly, the rate at which we can do this work depends a lot on how aligned we, Ascension Seton, and Central Health are. You know, we are partners, but we're not perfectly aligned partners. We'll never be perfectly aligned partners, but are there ways for us to take that step back and look for opportunities around this alignment so that we can have, you know, sort of more trust between us and mechanisms to more rapidly activate programs that are helpful to the populations that we all collectively care about. And that's it for me.
Thank you so much, Dean Johnson. It is really amazing what everyone has been able to accomplish. As you said, this is collaboration, working together during this most difficult 15, 16 months we've had during COVID-19. And we greatly appreciate what you and community care and everyone else, all the partners, Austin Public Health, working together have brought to our community, and all that you are doing with cancer prevention and other areas. And I do appreciate what you said. We want to make new friends, but keep the old. We certainly continue to care for the sick, but we would like to be in a position where fewer people are sick because we're focusing on health. Thank you so much. I see Minnie on here, Calhoun from the medical school. Minnie, did you have anything that you wanted to add?
Off to my boss.
Of course.
I want to recognize you. I see your square here, so I just wanted to recognize you.
Thank you so much. No, I think Julie said it all. I'd love to hear from you all. Yes.
All right, thank you. So members, I'm scanning. Does anyone? Yes, Manager Motwani.
I'm sorry, Chair, I'll defer to you, but I think Manager Besaita had her hand up for a while longer than me. I'm sorry.
Okay, no, thank you. It's again, it's hard to scan all the squares. So I'll take Manager Besaita and then Manager Motwani. Thank you.
Well, thank you. Thank you, Dean Johnson. Thank you, Minnie, for being here. I personally want to thank you for your leadership and your commitment to health and equity for our community. And I also want to thank your incredible staff, especially during this really challenging time. And I cannot imagine our community during this pandemic without DelMed. And I truly appreciate everything that you have done. I understand there were challenges, and there were challenges all around the world, but you have stemmed out, came out very strong, and your heart is always in the right place. And Minnie, your paper, when I read it, it was incredible. The sunshine calls, and sometimes we underestimate the little things in life. In my office, I have, it's the little things that makes life beautiful. And everything that you have done, you have made this community healthier, better, and more beautiful. And thank you for everything that you have done.
Well, thank you very much. It's been, again, it's all about collective action, and it's been wonderful to work in the community and see the community come together. I mean, the COVID stuff, boy, the amount of Zoom calls Mike Eastland and I did together through weekends and every day of the week. It was, we're all exhausted. So, yeah, but it was completely worth it. Other communities weren't doing this and they didn't have the kind of results that we did.
That's right. And when you talked about not having an outbreak among our neighbors who are experiencing homelessness, it's a true testament to you and your staff. Manager Motwani.
Thank you, Chair. Thanks for being here, Dean. I had a question about the number of the 140,000 doses. I'm guessing that's probably like somewhere 90 to 100,000 people or patients. I don't know, but something less than 140K. What percentage of those are the socioeconomically stressed population that we're often working with? Was that sort of population at large, or was it focused population? That's the first question. And then the second was that, whatever that subset was, and I don't expect you to have a direct percentage in your pocket by any means, but whatever that subset was, do you know if there's any long-term engagement with them, or were they kind of front-ended or front-ended into an EHR or anything like that?
Oh, that's a great question. So first of all, one of the most frustrating things, I guess Stephanie Morgan's on too, so she may be able to help with some more detail than I have. One of the most frustrating things was how poorly we reached the populations that needed vaccine the most. And I would say UT did not as well as CommuniCare. CommuniCare did a remarkable job, actually. They're in the communities that were hit the most and have that patient population. But even Austin Public Health, wasn't, even though it was citing its vaccine sites in the parts of town where they needed to be, it was still not getting proportionally the populations that needed the vaccine the most. And so I don't have that number for you. I doubt Stephanie has it either. I don't think Minnie's got it. We can get that for you, but it was disappointing. What we did to try to mitigate that, when everyone wanted the vaccine, we said, okay, the first people that are going to get it are coming from the most vulnerable zip codes. We weren't allowed to say, you saw what happened I guess it was Dallas, where they were targeting by socioeconomic status specifically or in race. Right. That didn't happen, but we knew we could target by zip code. We weren't given any trouble by doing that. And so we put those people at the front of the line, but it didn't matter because we were overwhelmed, by getting to the next tier, the next tier, the next tier. So it really didn't, we might've gotten to some of the vulnerable that stepped forward earlier, but it didn't solve that problem. So that has been one of the heartbreaking things about this. So subsequent to that, we put together programs that were specifically designed to get into the communities that need it at most, and to develop more alternative approaches to doing that. And Stephanie did describe some of those to you, bringing the vaccine to the people, to the churches, that kind of thing. And so those have been effective, but they're really inefficient. We can vaccinate a couple thousand a day in clinic, and we can vaccinate at one of those events 150, 100. And so it's, we still are going with all that and hope to, keep working hard at it, but it was frustrating. Your second question, yes, anyone who came in is now, in our system. And so they can be treated as a patient. So that does make it easier to capture, for them to navigate our system going forward.
And then I might just add, I loved your question, because it also talked about what's coming in the future. And so we've been raising additional philanthropy to actually take the initial inroads we've made and now bolster them. So we are recruiting community health workers, and this is all done through partners, because in the end, we will still be small unless we partner with everyone else. And we're trying to build much more of a network and support other people's networks so that we're a little bit more resilient when, God forbid, the next version of this crisis arises, which it will.
Thank you. Managers, any other questions? Let's see, Manager wanting to answer yours. Manager Jones. Manager Jones, did you have a question?
Yes, I think Manager Valdez was before I was. So. Okay.
Thank you. Manager Valdez, did you have a question? And then Manager Jones.
I'll let Manager Jones go first.
Okay.
Manager Jones and then Manager Valdez.
Okay. I guess my question is, having learned, first of all, thank you for the work that you all are doing. You've done a fantastic job in working with the partnership in the community and addressing this pandemic. God willing, over the next year, we'll come out of it a little better, and that we'll be in a position better to address health inequities in our communities. My question goes to working with Central Health and others. Do you see or can you envision visible locations working in these areas geographically that we've identified that services the various demographic populations, having your residents and others out there visibly working? And can we talk about planning to make that happen? Because as a board member, I'd like very much to see, and you've done great work in terms of partnership with the university there, but it'd be very helpful to have you visibly out in the Eastern Crescent and other areas, and people know that you're there and are able to make appointments through our arrangements or others. So do you have that envisioned in terms of helping us to address the issues we've identified?
Yeah, let me turn this down. I think that's a great question. So, we are in Southeast Health and Wellness Center. So we have residents that spend time out there, but we're not well, there are a few other places where we are, but, small sets of residents and students. Yes, we need to work with community care in coming up with a plan to have them in that setting much more. And we've had these conversations already with them. There's a possibility that we need to explore about them being an academic FQHC, which allows us actually to site residents there. And it is a priority for this year to complete that evaluation with them and to see whether we can use that as a means to not just send our residents there, but actually to grow those programs. The other opportunity we're missing by not doing that is there are a subset of med students, we get a lot of them, but that are these like amazing do-gooder people, right? They like to help the sickest and most needy folks. And they love to work with the homeless and in the Eastern Crescent. They don't want to be treating, VIPs and all of that. Although we concentrate on, that we treat everyone obviously in our hospitals, and we tend to have as a level 1 trauma center at Del Seton more folks from Eastern Crescent. It's not the population they really want to target. So if we can build out more of those opportunities, we're going to have more future, clinicians too that will stay. And with the vision mission of the school, I think there's that for them to stay and not just care for those patients, but think about the system and system intervention. I think that could be multiplicative. So I am excited about that. Thank you. Please hold us accountable and ask us next year about whether we made progress on that.
And those residents have the opportunity to see the environments in which their patients experience, and helpfully maybe be able to understand their perspective as well. Thanks very much.
Thank you. Manager Valadez.
Thank you, Dr. Johnston, for this great presentation and for the information that you provided. However, I have some questions. And I want to thank you also because I know the feds reimbursed you for the vaccinations that you received. And I'm going to give you a just suggestion. Next time, let's see if we can get you to work with the Austin Latino Coalition, who worked so hard and diligently in our population that had over 50% of the deaths that were experienced here in Travis County. One of the things that I didn't see was any metrics or data as to how you served or how many people you served in the uninsured rather, and indigent population, which is our population that we were created to serve. Working with APH is one thing, but working with our population is another. So that's something I would like for us to see as Central Health, if we're going to be partnering in the future. What exactly have you done, has the medical school done for our uninsured and indigent population? I'm talking about direct benefits, direct services. And I did notice that in the information that you provided to us, it appears as if about 1/3 of your $35 million is overhead. So taking that into account, I have some questions that I put together on a little spreadsheet here. If you don't mind me, I'll go as quickly as possible. With respect to women's health, how many patients and low-income women access your fetal care center and special delivery unit at Dell Children's? And did Dell Medical School bill Central Health for any of these services? I'm gonna go to the next one, or unless you want to answer.
Some of these I'm not going to be able to answer. They're not, I mean, just because they're details, but I'm happy to receive that sheet and give you.
I appreciate that. Was going to be my suggestion, Manager Valadez. I think probably what would be best is to submit that so that he can get back to his staff. We can't expect Dean Johnston or Minnie to have these answers. So let's submit that to him, because I was going to have.
I will.
Manager Valadez.
I will.
If I could continue, and then I'll get back to you, because Dean Johnston, I know that you haven't completed your budget yet due to the fiscal year of the University of Texas at Austin, which you're part of, but will you be able to return and brief the board more fully regarding your budget and items of expenditure once the budget is completed?
Yes.
Okay, and maybe at that time, Manager Valadez, these questions could be addressed too, I'm thinking. So and you could submit them. How does that work?
I want to tell you you're psychic, but because what I was going to say, if I hadn't allowed to finish my sentence, was I'm going to get these submitted to you. If you could maybe have your staff or whoever's responsible for responding, if they could send them to our Central Health staff so that they could distribute them to our board members so they could see the questions and answers in advance of that board meeting when we can talk about numbers and budgets. I would be greatly appreciative of that. Thank you, Minnie, and thank you, Dr. Johnston. And I appreciate your you're offering to provide us that information. Thank you very much. I can't tell you how much I look forward to a continued relationship with UT Dell Medical School. I'm especially interested in you all pursuing and continuing expanding the pipeline program, which is something that we have been advocating for since long before you ever got here. And one more thing, I just want to make sure that that you really do get a chance to tell us how you're dealing and how you're providing services to our indigent and uninsured population, because you may be the only entity we may be working with that is going to be open and accountable for the dollars that you receive and for the patients that we are sending to you. Thank you very much.
Thank you, Manager Valdez. I know you have very specific and important and insightful questions because we do need the details on our patients. I wholeheartedly agree, but I know that they're operating on a different fiscal year. So if you could, as you said, submit those so that all the board can see your great questions, and then we'll work with Dean Johnson and his staff to see when they're going to have their budget complete and when they can come back with more details on these items of expenditure. Thank you.
I thank you, Madam Chair, and I thank you both at UT. And I also want to thank the public for having passed the opportunity for us to provide monies to you. However, with you getting those monies also sets you up for being accountable for those dollars. And that's one of the things that I'll base my questions on. Thank you.
Absolutely. That's why we'll look forward to getting to them coming back when they have the budget finished and can respond more specifically to that. Absolutely. Right. Accountability. And please accountability.
Please don't forget to consider working with our community organizations that have worked so diligently and continue to work in providing our hard to reach populations access to vaccines, PPE, and COVID tests. Thank you.
Yep, and I'm meeting with them soon, actually, Manager Valdez. So,
thank you. I appreciate it.
Thank you. Any other questions? I'm scanning, but if I miss you, please just, speak out. Manager Musaitev, did you have something?
Yeah, mine is really brief. Do you have any plans of expanding your applicant pool, I think, for students? So is it still 50? When's your plan of having more students?
It's still 50. And it's a great question. I think we're getting to the point where we could grow slowly. Training medical students is expensive, and we are training, as you all know, leaders, and training leaders is even more expensive than just training clinicians, right? So, so that growth is expected to be slow. The growth in the residency programs is dramatic, and we are going to add additional fellowships there. And that also has a potential to grow the local workforce in important ways. In some ways, it's easier to get to, you want to influence them early enough that you change their life course, how they define their career. But residency might be okay for that because of our reputation. So, I think that's the other way that we'll expand and have that impact.
That's wonderful. Thank you.
Thank you so much. Well, we are very appreciative of your time and of Minnie's time and of all your staff. I sincerely hope that both of you and all of your staff and others who have worked hours beyond what we can comprehend can please take a little time off to recharge and get away. And we will look forward to seeing you at a future meeting when you have the budget details. Thank you so much. We appreciate it.
You bet. Thank you all.
Take care.
Thanks for your service.
Thank you for yours. All right, members, we are now moving to item number 3. Consider and take appropriate action regarding the granting of an approximately 0.1075 acre sidewalk easement to the city of Austin in connection with the realignment of Red River Street adjacent to the Central Health Downtown Campus. Jeff Canodal and David Duncan will be presenting, so I will turn over to them.
Yeah, thank you, Chair. Jeff Knodel, CFO. Good evening, board members. This is somewhat of a routine item. It's the conveyance of about 1/10 of an acre related to sidewalks on our downtown campus. The conveyance is to the city of Austin. At that point of conveyance, the city would be responsible for maintenance of those sidewalks. And this is a really typical action that usually occurs on developments as it relates to both streets and sidewalk construction. So David, I don't know if there's any more that you'd like to add related to this item.
No, this is just to mention to the board members, you may recall we worked on an interlocal agreement with the city. This is consistent with that and goes along with that. And also we negotiated an amendment to our lease contract with 2033 Higher Education Fund. There is just a small unusual thing about this easement is they have to sign an acknowledgement on this as well because it's actually transferring land that's part of their lease. But again, that's all been dealt with in our amendments with them, and it is consistent with the ILA with the city.
Thank you very much. Members, any questions? If not, we can proceed. Is there a motion? Manager Valdez?
Yes, where's Dr. Bell? For the exact language, I'll second Dr. Bell's motion. I hear.
I got it. Okay, I move that the board recommend that the Travis County Commissioners Court approve the granting of the sidewalk easement in connection with the realignment of Red River Street to the city of Austin.
Okay, a motion by Manager Bell, second by Manager Valadez. Any discussion? Don't see or hear any, so members all in favor, aye. Aye. Opposed, same sign. Abstaining, same sign. The motion passes. Thank you, members. So we will now move to item number 4, receive and discuss a presentation on the proposed Central Health fiscal year FY 2022 budget, including proposed healthcare delivery services. Mike Giesen will open the item, and presenting him with him will be Jeff Knodel, John Morgan, Dr. Alan Shulshaw. Welcome, Dr. Shulshaw. We saw the announcement in the email, and we're appreciative of you joining us. And Lisa Owens will also be presenting. So I'm going to turn it over to all of them.
All right, thank you. So I'll tee up tonight's conversation, members, and then hand it over to others to present on this. So can you all hear me okay?
Yes, sir.
All right, thank you. So tonight you'll notice some different formatting, and it's designed to show the strategic objectives that were adopted by the board, what the funding levels are, and how that lines up with the work to be performed. Just to perhaps oversimplify it, but trying to bring the formats to show, how the money results in the work to be done. There are going to be some additional conversations that we've already kicked off at the management level, and that will bring the board into more and more awareness as we refine those conversations around how we achieve organizational excellence. Now, we've already had some discussion with the board and on a number of presentations regarding our culture as it relates to the diversity, equity, and inclusion of our workforce, or our hub disparity study, and trying to improve upon the diversity and inclusion of those with whom we work and partner with outside of our staff structures. But we will need to begin taking a much more critical look and examination of the different operational improvements that need to be made within Central Health, but also how we support community care in Sendero. And these types of operational improvements involve technology, it involves human resources, it involves procurement and contracting, and I could go on, but there's just certain things that you have to do as an organization that are your basic blocking and tackling, regardless of what you do that's outward facing. There are some things that you just simply have to excel at. So again, this is somewhat of a tee up, but it's also a placeholder for some future combinations. All of this, of course, culminating in the budget resolution that the board ultimately adopts, which, again, as an expression of policy, adopts the budget. The budget is a form of policy, but also aligns it with the strategic objectives that have been established by the board of managers. Lastly, Manager Valdez, you had forwarded some questions to us in advance. Again, thank you very much for doing that, and appreciate the precision of the questions. We will be addressing those with the board in open session. That way, the board, as well as the viewing public, whether you're watching live or you watch the recorded version, has the benefit of knowing what the question is, but also hearing the answer as well. It's also a way of helping us keep a record of that. So we will not be able to get to all the questions tonight, but as the budget process, has many steps to it, we'll take advantage of those steps to bring back answers to those questions, so that by the time you make a decision on adopting the budget, you've got the information that you need to make an informed decision. At this point, I will turn it over. Thank you.
Thank you, Mike. Jeff Knodel, CFO. I'm going to open up the presentation. I'll make a couple of comments before we start. First comment is just welcoming Dr. Chaucer. We really are looking forward to working with him on a more formal manner. He's been in an acting role or interim role for a bit, but are really looking forward to engaging with him on improving healthcare. Secondly, related specifically to our budget, Central Health was recently awarded the Government Financial Officers Association Budget Excellence Award. Y'all have heard us refer to this as just the GFOA Budget Award. This award meets guidelines that are established by the National Advisory Council on State and Local Budgeting and the GFOA's best practices on budgeting. So this was our second year to apply. It's our second year to receive the award. So in that context, I would really like to show specific appreciation to Lester Hanaher and Lisa Owens in doing all the work, doing all the hard work to make this a successful application. And I think it goes to show that the finished budget product that Central Health produces meets excellence standards that are judged by third parties in that regard. And then last, before we kick off our presentation, just as a reminder, this is our fiscal year 2022 proposed budget with an emphasis on proposed. So there's still a lot of meetings that will happen. As Mr. Giesland mentioned, there will be time to address questions that board members may have. We are not asking for any action tonight. This is all part of the proposed budget process. And we will either try to address questions after the presentation or take those questions down and bring them back in subsequent meetings. Next slide, please. So I'm going to open up with several slides. I think the board has seen almost all of my slides, so I'm going to go through them fairly quickly. The first slide shows just our fiscal year 2021 budget and where we're at today at a really high level related to our fiscal year 22 proposed budget, and then just a variance column to the right. There are a couple of major things that haven't happened. We're still in the proposed budget process without a certified tax roll. And so we've had to estimate the tax rate based on estimates from the Central Appraisal District. And so we're estimating, you see at the top, our estimated tax rate. And then you see our sources and uses as a comparison from fiscal year 2021 to 2022. And we'll be going into a lot of detail related to these numbers in the presentation. And then at the very bottom, you see our emergency reserve funding level, which has not changed from fiscal year 2021 to fiscal year 2022. Next slide. So the next slide is our, and again, you saw this last meeting, shows 3 years worth of proposed tax rate calculations. There's actually a lot of information on this slide. You see the 2 years worth of actual average homestead values, and then the fiscal year 22 estimate that we received from the appraisal district. The second row, which is interesting, is the jump in homestead appreciation, just aggregately from 2.2% to 8.7%. And, you know, one thing to keep in mind, just generally speaking, is homesteads do have a 10% cap on them. So it's right around the upper limits of increase, obviously not at 10%, but much greater than it's been in the previous year. And then you see some detail on our tax rate. And then our tax bill, again, just as a comparison with the average homestead tax bill being $441.30 based on the average homestead value of $386,000, $341 at the top. And then lastly, I will report down at the bottom that at the last meeting, the Central Health Board approved recommending to the Travis County Commissioners Court increasing the over 65 homestead, 65 and over homestead exemption and the disability homestead exemption from $85,500 to $100,000. That was approved yesterday at the court, and we'll move forward to the appraisal district to convey on the tax notices that are sent out. On the next slide, our budget is tied into our proposed strategic priorities. And you see the 3 priorities listed: developing and executing healthcare delivery based on people in place, implementing patient-focused and coordinated healthcare system, and sustainable financial model for healthcare delivery. And throughout this presentation, we try to hit on the structure that we have related to our strategic priorities for fiscal year 2022. And I should have mentioned up front, this was talked about at length at the Strategic Planning Committee, and there will be future discussions in future meetings related to this. So I just wanted to include this slide just as the framework for both our budget development and then ultimately our budget resolution that we develop towards the end of the budget approval process. On the next slide, we begin tying in the objectives into our budget and our actions that have occurred. This slide shows action that the board has taken related to objective 1, which is developing, executing healthcare delivery based on people in place. This slide just shows the 3 clinics in Eastern Travis County that the board has approved the budget related to the clinics. The Hornsby Bend and Del Valle clinics are progressing along, and you see renditions of the clinics that have been presented in previous meetings. And then the Colony Park budget has also been approved. It's a little behind the schedule of the other 2. We're currently in ongoing negotiations related around the land purchase of that site at Colony Park. The next slide related around objective 1. And again, this was a slide that we showed last meeting, so I won't belabor it. Just shows our long-term capital budget. It shows by category over the next upcoming 6 years, our capital uses and our capital sources. So you see up in the upper half over the 6-year period, the categories of capital budget that we project to spend. And again, these are, budgets are always estimates. So these are long-term projections, but you see broken down by subject functional area, the spend, and then down at the bottom, you see the sources as far as how we're funding those. And you'll see two types of sources. Either we're funding the capital projects through our capital reserve, or we're debt financing or using our line of credit related around financing of these capital projects. On the next slide, related to our objective around sustainable financial models, hopefully you guys have seen, I mean, you've seen this a lot, and this has been a long-standing format that we've utilized to do long-term planning. So this is the last slide that we showed last board meeting related around our proposed tax rate of 6% over the no new revenue rate. And again, it shows our reserve levels, paying a lot of attention to the gray line. Our objective on this whole slide is to take events that we know will happen in this current period, in this 6-year period, plus inflating any services that we provide today that we know will cost more in the future, using some real broad-based assumptions and trying to forecast from a long-term perspective, looking at our tax rate, our property tax rate, trying to really be cognizant that we're trying to set our tax rate over this time period in a real level manner. We don't want to have a lot of volatility year to year, and that we're setting ourselves up, we're setting Central Health up to be successful and sustainable as it relates to providing the services that it expects to provide to our community over this period of time. Next slide is something that's a little bit new. I'm going to spend a little bit more time on it. As we look at other revenue sources other than property taxes, we've been looking at for a 10-year period, or actually this table looks at a 10-year period. And our eye really is towards looking at diversification of revenue over a period of time. And so in fiscal year 2022, we are budgeting for lease revenue from the downtown campus of $13 million. The table on the right shows a 10-year period, and let me spend a little time on the table. There are 2 columns. The first column shows actual revenues and expenses from 2018 through 2020. So you have that time period based on actuals, and then we're estimating or projecting our revenues related to leases that we have in place for that time period. And you see 2 specifically listed items. You see the continuing education building with the park and the parking garage lease. You see the expected revenue over that time period. Also included or not included in it is the continuing education lease actually expires in 2024. because this time period exceeds that, we don't know what that holds in the future, but we did not include any additional lease revenue subsequent to 2024. And then of course we have a long-term ground lease with the 2033 fund. So you see that totaled up, and then you see the uses that we've had on the campus. You know, the two primary uses or costs related to the downtown campus is the Red River realignment and the UMCB tower demolition. And so you see both the actual and then the estimated completion of those projects, plus some other costs related to the project. To me, the takeaway on it is kind of on the bottom, which is the net of the sources and the uses during that 10-year period, just showing that we're increasing over time our diversification, both in increasing the amount of revenue that the campus is generating, plus increasing at a much quicker rate than what our property tax amounts will provide over the next 10-year period, which will increase the diversification or the mix of that revenue over the long term. And then lastly, I would just mention that the headquarters consolidation and clinic expansion, as it relates to looking at our lease cost and leasing cost over 30 years. And we spent a lot of time discussing this, that we estimate to save over $100 million over a 30-year period. That concludes my part of the presentation. I'm going to turn it over to the clinical portion of our presentation.
Thank you, Jeff. Can you all hear me okay?
Yes, thank you.
Thank you, good evening, managers. I'm John Morgan, Chief Operating Officer. I need to warn everybody in advance, they're doing some work on our fire alarm system here at the atrium tonight. So if you hear a fire alarm, I've been assured that the building is not on fire, and it is also not on your head.
Thank you. I would be worried. Thank you.
Tonight, Dr. Shalsha and I are together going to highlight the healthcare delivery aspects of the budget, specifically those that pertain to Objective 2 of the strategic plan, which is implementing a patient-focused and coordinated healthcare system. As you all are aware, our team is deeply engaged in a planning exercise to identify and priority gaps across our safety net healthcare system. You all have seen this slide here that represents that planning effort and that we refer back to in multiple settings, but we're working to prioritize those gaps and lay out a multi-year plan to address the gaps in our system and improve access and quality and address healthcare disparities within our system. Because that planning exercise is anticipated to span 2 fiscal years, for this year's budget, we've tried to identify focus areas where we believe we should begin our work immediately, while continuing the systems planning going into FY22 for services and initiatives that would take place in FY23 and beyond. I believe the board is scheduled to accept a generous grant tonight from the Episcopal Health Foundation that recognizes and supports that critical work in our community. Lisa, would you go to the next slide, please? As Jeff mentioned, as a reminder, we initially presented the 6 proposed focus areas at a previous strategic planning committee. And we've been going through a process to have deep dive discussions and presentations on each of those proposed focus areas. So far, we've covered the demographics and clinical characteristics, disparities in care for our populations, gaps in care, and immediate initiatives related to those first 2 bullets in specialty care access and in the healthcare for the homeless, and including our medical respite work. it's important to note that in August, we'll be back to share our work related to the other 4 bullets, behavioral health, substance use disorder treatment, the transitions of care, and the clinical and patient education. So we still have a lot of deep dives and material to cover with the board at the next strategic planning. But we will touch on some initiatives and some dollar amounts that are associated with those focus areas tonight. But just know that in August, you'll get a lot more detail about those. Before I turn it over to Dr. Schulsche, I want to spend just a couple more minutes on this slide, really to help orient the board to where you can expect to find the specific initiatives from these focus area discussions in the budget for FY22. There are certainly areas of overlap, but generally speaking, the specialty care access focus area corresponds to the specialty care access line item in the budget. And that's reflected in the $3.2 million increase in funding for specialty care going into FY22. Healthcare for the homeless, behavioral health, and substance use, those initiatives largely appear in the primary care line, although they could arguably fit in several different lines. Part of the work that you'll hear about in August is that we're really emphasizing the infrastructure and the investment in homeless services, behavioral health, and substance use in the primary care setting and at the lower end of the acuity scale related to diagnoses in those areas. Those initiatives are represented in the $2.53 million increase in that top line for primary care that includes medical, dental, and behavioral health. There are also a few initiatives here that I'll mention that are service enhancements that really fall outside of our 6 clinical focus areas, but they represent significant enhancements and expansions in care, and really wanted to call those out. The first is that our systems planning effort is really pointing to the fact that we have a lot of work to do in building out dental capacity in our system. As you all are aware, Central Health is often the only governmental payer for these services. And due to the nature of the services, it can take years to build out significant additional capacity. So we really don't want to wait. The site requirements, the equipment needed, these are really space dependent services, and we want to take advantage of the time we have and get started in that work. We're also planning to offer enhanced or additional services to our MAP basic population. We hope to expand access in urgent care, in certain post-acute care services like palliative care and hospice, and specialty care services that are currently unavailable for this population. For those of you who were here at the time we created the MAP Basic program a few years ago, you'll remember that we talked about creating the program itself was critical to provide the infrastructure for us to expand access to services that aren't traditionally offered by our FQHC partners. So now that we've got that program online, we have a lot of opportunities to expand access to care that we wouldn't have had had we not taken the steps to create that program. Importantly, we'll also continue to enhance our pharmacy benefit services. And really, as we expand access to care, we have to expand access to the pharmacy services that support that care. The largest change we expect to make in that area is working to align the MAP Basic program, pharmacy program, with the MAP program, in that a MAP Basic patient would be able to have prescriptions filled regardless of who their prescriber is. When we initially put that program into place, we limited the prescribers in order to test our system and put processes in place, and limited it at first to just the FQHC prescribers and a few select specialists. But as we grow the services, we need to bring that pharmacy benefit up to match. And finally, our staff and the Board of Managers have identified the need to increase the enrollment period for our MAP patients from 6 to 12 months. It's a long overdue change, and we're continuing to work with our partners at Ascension Seton to make that policy change. What we've included here in the budget in a section called MAP Eligibility Enhancement Reserve is an estimate for the additional expenses that we would expect Central Health to incur related to that change. And that's a $2 million line item. Finally, I should note a few substantial decreases in the budget, those that are associated with the hospital and specialty care services, or what was budgeted in the current year at $57 million, the hospital performance incentives at $2.7 million, and post-acute care is a little bit complicated, which was budgeted at $5.4 million in FY21. For FY22, it removes the aspects that are associated with the hospital funding model, but it includes additional services that I mentioned associated with those MAP basic benefit enhancements. All of those three lines were associated with a potential new hospital funding model that you all have heard quite a bit about. And those have been removed, as we do not expect at this time that we're going to have a new hospital funding model that would take effect in FY22. I'm happy to help answer questions at the end, but at this point, I'll turn it over to Dr. Shalsha, who's going to briefly discuss the initiatives and the budgets associated with those 6 clinical focus areas.
And again, welcome, Dr. Shalsha. We're so happy to have you on board now in this capacity.
Thank you. Thank you so much. Can everybody hear me okay?
Yes, sir, we can.
Thank you. Thanks, John. Good evening, Chairperson Greenberg and Board of Managers. Thank you for the very warm welcome. And I am ridiculously excited to be here. I thought that the fire alarm was actually kind of a test for the new guy. So if it goes off, I think John is just doing that. Also, obviously, excited to be participating with the Central Health team because we get to continue the work that the folks within community care and our other enterprise partners have been doing over the past few years. And so it just allows us to move, continually towards kind of health equity and move these initiatives. As John spoke to above each slide, you'll see kind of the budget amount that's allocated for the subgroups below. Many of these, again, to John's point, you've seen before. In August, we will do a deep dive as related to behavioral health and substance use disorders. And I'll cover some of these in some greater detail, and other ones I'll just touch on briefly. For cardiology, endocrinology, and nephrology, we will just be adding resources. This will be both in clinic visits and through e-consults. Recently, CUC was approved to add neurology in scope. And so this is going to serve as a dynamic resource in an ambulatory setting for our patients. And we've had critical need for a long period of time. Second podiatrist starts, I think, next week. Our podiatrists will serve in an ambulatory setting and in an in-hospital setting with our Seton partners and within an ambulatory surgery environment. And that is all being worked kind of in tandem. The critical importance of the podiatry patients and the podiatry providers working throughout the continuum of care is, number one, if they get to know the patients in the ambulatory setting, they can follow them into the surgical setting. The key to them conducting the surgery is these are limb salvage specialists. And so the surgeries can be much more acute. The lower down the surgery, when it's conducted, let's say below the tibial tuberosity, so on the lower leg, the greater the chance for the patient to actually ambulate, get up and walk. And this decreases future chances of morbidity and mortality, and obviously increases quality of life. So these are big wins, and we're very excited about this. Rheumatology, we're going to be increasing access to care. Obviously, with our podiatric increase to care, we need additional root care. In addition, our patients experiencing homelessness have significant needs in that environment, as well as individuals with a diagnosis of diabetes. So we'll be adding resources there. E-consults will serve all of these specialties, both to more efficiently address patient questions and provider questions. Outpatient dialysis, the more we can dialyze patients either in a clinic setting or within their home, the greater their health and well-being will be. If we can avoid compassionate dialysis, which is actually our patients reporting to the ED and being dialyzed there, again, the lower the cost and the healthier the patient. In addition, we'll be increasing diagnostic procedures such as echoes, cardiac stress tests in an ambulatory setting, so that our patients in an outpatient setting can get more diagnostic tests that can then govern the next point of their care. We will have care teams working on medical weight loss. There's been a lot of work done and studies have advanced in this environment. Some of the new medications that are out show endpoints that come very close to some of the surgical procedures that are conducted for folks who need those procedures. And so by putting together teams, we think we can actually improve the health and well-being of our patients. Next slide, please.
Alan, can I jump in and give you a break just for a second?
Sure.
Lisa, if you'd go back, two things I'd point out for the board. One is on this left-hand column, a lot of these are services, specialty care service lines that we introduced recently in the FQHC environment. So a lot of the work going into FY22 is trying to build on that, build on those initiatives and add capacity. In some of these services, we have a single provider that's providing that specialty care. So a lot of the work for FY22 is recruiting additional specialists, adding capacity and redundancy, so our providers can ultimately take a vacation occasionally. The other thing I'd point out on the right-hand column, these are really about comprehensive programs getting developed. And there are a lot of aspects that go into them, and they touch on a lot of different specialties. Podiatry, for example, we've talked a lot about building in the integrated behavioral health that's needed for patients who are going through amputations and that kind of acute care. And those are details that are buried within each of these. But that's really why we've separated out the left side from the right side. Is you've got your clinic expansions and e-consults on the left side, and really comprehensive program development for new programs on the right. I'll turn it back to Alan.
All right, thank you. There's an increased need for medical respite. A medical respite can be everything from once a patient leaves the hospital, step-down care, to really concentrating on finding a place that is clean, dry, and safe for our patients, actually just to heal, for them to get better. So we will be looking at partnerships to increase that capacity. As related to street and mobile, we'll be at least doubling the access that our patients have. In addition, providing vehicles where patients can actually have a visit in the environment or close to the environment in which they live, that maybe affords them a little bit more privacy, and resources can be contained within that vehicle or those vehicles. Obviously, as our services and access to patient care increases, so our need for case management. We've already increased case management, and this is going to continue. John started off by talking about the cogs of care, and those really illustrate kind of disparate care environments. We need to help our patients navigate through the system, again, in order to help them really succeed. One of the areas of opportunity that we have noted recently is there are patients who are discharged from a hospital setting where they need either IV antibiotic use or need to be maintained on complicated antibiotic regimes. And we've kind of had a gap in the system over the past few years in that environment. So we're going to be investing in increasing access to infectious disease support in an ambulatory setting. For mental health access, about 70% of the mental health needs of our patients can be covered within a primary care environment. 25%, will need to be cared for within our mental health authority, and so partnership with integral care is obviously critically important. But whether it's behavioral health or psychiatric care, we need to advance both of those significantly. Next slide, please. As far as behavioral health access, if you think about our patient populations, many of our patients experience childhood trauma or the cultural trauma from being in a new environment. We have to increase access to behavioral health. For our individuals who experience homelessness, they need care right then and there when they need it, right? And this is both behavioral health access and psychiatric access. Again, we need to partner very closely with Integral Care, but many of these patients can be cared for directly on the street in the primary care setting, or can be we can partner with Integral Care, and when those patients are stabilized, then they can be managed, in the environment in which they live. So this is a really, this is significantly important initiative or initiatives that we're going to be expanding. For substance use disorders, when patients transit, we think about substance use disorders as chronic diseases, right? So these last months to years, and so when patients transition from an in-hospital setting to an ambulatory setting, we need to help them with those transitions. Those are areas of weakness within the system. And so we're going to be investing significant resources in expanding kind of those transitions. In addition, the same points that I just made about substance use disorders being chronic diseases, the evidence really is clear that peer support is significant in longitudinal success of our patients. And so looking at developing, building, contracting for peer support counselors is an important part of our initiatives moving forward. Next slide, please. We're going to be looking to increase our dietitian support both in our communities and within our FQHC's environments. For our initiative that we're looking to pilot within our communities, we're going to hire a dietitian and some community health workers. There have been some recent studies that really show that many dietitians don't understand the patient's environment and the patient's kind of cultural specific dietetics or what is actually possible within the environments in which they live. If we think about patients who have a diagnosis of chronic kidney disease, patients who have heart failure, patients who have diabetes, it's critically important for us to take our nutrition expertise and our specific community awareness and cultural awareness and marry the two in order to be successful. And so the first initiative on here is really geared to do that. As far as the availability of nutritionists within our FQHC partners, there is a significant need as well. And so we will be expanding that. Those initiatives, health equity and implicit bias training is central to everything we do, we should do, and we should continue to do. And so Central Health will be helping facilitate and empower our partners within the enterprise as related to training. And then one of the initiatives that we learned was so important is different methodologies by which to allow patients to succeed in their care, right? So telehealth during the pandemic really was critically important to our patients and our communities. We have a pilot or a couple pilots going within our FQHC partners as related to in-home monitoring. And again, if we could remove barriers to care such as transportation or patients having to leave work, we stand a much greater chance of succeeding with their care. And John, I'll turn it back over to you or stop there. Thank you.
Nothing to add. Thank you, Alan. I think it goes to Lisa from here.
All right. Thanks, everybody. Okay, I'm going to go through a few new slides for you tonight, a little bit more detail on some of the healthcare services, healthcare operations and support in the administration programs. But good evening, Lisa Owens, Deputy CFO. So we wanted to prepare additional information. This all, does tie back to what we refer to as Attachment B, which is the much more details on our uses of funds. And this year, we had talked about this last year, we have included additional information by some of the functional areas in the healthcare services and operations to just show you where a lot of the investments will be made in staff and in other goods and services, professional services, and contracted services. So in this section, we're sharing with you our healthcare operations departments. And they're summarized by the proposed budget in the first row, the total FY 2022, and then last year's budget. So you can see where some of the increases are and drivers of any increases. And then we also provided to you the budget, the proposed budget, full-time equivalent employees, and last year's budget of what was in the budget. So you can see where that change is. And our hope is that we can also bring back to you in fiscal year 2022 monthly reporting that coincides with this, so we can also see this level of detail, especially on staffing levels and other areas that have been requested in the past. So looking at the next slide, this is the section that all those departments roll up into. And so I just want to kind of highlight that and bring it back. It really is in these areas, salaries and benefits, all the way down to other operating expenses. That is where our staff that work in those healthcare operating departments are, and the services that they use, contracted services, professional services, but more importantly, the very robust business case process that we've been using for the past couple of years. So most of our new staff, all of our new staff proposed in this budget, and significant additional dollars in certain areas will be driven or supported by the 20 business cases that we received and we had talked about at our last meeting earlier in June. So I just want to highlight that we did talk about increasing eligibility services, joint technology investments, and clinical practice growth. And going back to this area here, you'll see that growth here as well as in some of the dollars. Also in our healthcare operations and support is our very important ACA healthcare premium assistance programs with Sendero. You'll also see about $1.5 million additional dollars in that area this year. And our healthcare facilities and campus redevelopment, as just Jeff talked about, we continue to redevelop the campus, but also significant healthcare facilities now out in Eastern Travis County. And so these would be dollars that are budgeted for the real estate team, real estate services, and items that are not included in our capital budget. Next, I want to just show you same version of the summary of the functional areas of the administration program. Again, the first row shows our proposed budget, and I would really like to highlight, as we talked about earlier, with no meetings in July and kind of accelerating our process, we will see changes between now and the final budget, especially as we're still working through our business cases and making sure that we get those numbers in the right spot. Is it capital? Is it professional services? Is it a staff person? So that work continues. And so later this summer, you might see some changes to those numbers, and we will ensure to highlight those when we bring back the final proposed budget in August. So just a preliminary look here. So again, as we've talked about business case supported changes, I would highlight for finance and procurement operations, there were some positions last year that we budgeted for as a professional service or contracted service that became an FTE. So the dollars were there, but there were 3.3 positions this year that does make it look like we had a bigger increase than when you look at what was presented in the business cases. So just want to make sure and highlight that. If you'll recall, a great example is the disparity study. We added that to the budget towards the end of the fiscal year budget preparation last year, and those dollars were put in professional services, and we've got a great program manager running that disparity study with our consultant, and that resulted in an FTE. Again, this ties back to our administration program, which is on attachment B, an increase of about $1.8 million this year. And again, supported by this business case process, additional organizational development, and communication support. So with that, we've really tried to pull together a lot of information focused tonight on the uses of funds. This is obviously the largest part of our work, is making sure that our dollars line up with the strategic objectives and the priorities of the organization. So our work tonight was an effort to really allow you to see where that is in the budget. As you know, when we come back in August, we'll be very focused on setting the tax rate. We'll have a final roll from the Travis County Appraisal District, and we will have some small changes to the uses of funds, but we feel like this is a really great comprehensive summary and appreciate my colleagues' support on the healthcare service. So just to wrap up, again, significant investment in healthcare delivery. We've been talking about it at strategic planning, at budget and finance earlier this month, and we will continue to focus on this as it is our priority. Increasing investments in MAP Basic. You know very well that we now have a clinical practice that's developing. John and Dr. Schalscher talked about podiatry and the changes that will be coming our way to support that work. And the system of care planning, which will be a multi-year effort to continue to build out those gaps. And then finally, as we talked about in the last few slides, just the operational excellence that we are focused on, using business cases and supporting all the healthcare services through the right-sized and excellent teams that we have working throughout Central Health and the enterprise. So as we always like to close with what's next, we have a lot of meetings coming, but none for a good month. So we will be back August 4th for the Strategic Planning Committee. We did talk about additional healthcare services will be presented there. But we really do start the tax rate setting. We will get the certified roll from Travis Central Appraisal District at the end of July. And we will have a proposed budget. We will bring that back to you in early August with a proposed tax rate. And then August 25th, we'll be coming back to set the maximum tax rate, and that really starts the public hearing process. Community conversation will be held, and then going into the public hearing, and finally, the request for setting the tax rate by this board and the commissioners in September. I also would just like to highlight my colleagues in the community engagement department have done such a great job shifting to opportunities for community engagement and just one-on-one engagement, leaving comments about our budget. And I hope that people will visit our website and go to that new engagement form that we're using for the budget process, because we do have many meetings where people can participate, but we also have a very robust platform that is available late at night, early in the morning, and whenever people can give us their feedback. And with that, I will turn it back to you, Chair Greenberg.
Thank you so much. I really don't know where to begin. I am just amazed by the breadth and depth and excellence of the work of everyone who presented and all those who assisted you who aren't here. So thank you. You know, the information was really incredible, and the tying this to our strategic objectives and looking forward to those and to some of the issues we've discussed for quite a while, such as moving towards that 12-month enrollment and some of these other very important initiatives. Members, I will now open up. So if you have questions and I don't see your hand, please get my attention. Manager Valadez?
Can't believe nobody else had any questions first. But anyway, I want to thank all of you guys for the budget questions. What I'm going to ask is something that I don't believe I've asked or included in that sheet. So I'm going to send some more questions. Basically, just to start off the bat with the budget, the CH, CCUC, and CCC budgets, I'd like to know, why do we not have CUC budget that's more than one page and that is actually including coming up to at least June? We're already in July 1st. And I just want to know when we're going to get that, because I'd like to know what their financial condition is, and I'd like to have it before August so that we can look at it and the public can see it as we go into, as we always have every year, multiple meetings on our budget prior to going to Commissioner's Court. So that's one thing. with respect to the 53 million less for healthcare services, from what I can see, why are we only spending 53 million plus less for healthcare delivery services? I'm just going to read them off. Somebody can hopefully listen and respond or tell me they'll get back with me. With respect to the 3.2 million for specialty care, what does specialty care access really mean? I mean, what does that mean? Are we as Central Health going to now be paying providers separately? Or is this anything that Seton maybe was providing before and they're not anymore? How much capacity are we actually adding? And what are the numbers or the data showing as to how we're doing with respect to that? How many services now and how much overall rather, I can't even read my own writing, is being spent on each area, a specialty area now? Are there services that Seton was providing and Central Health, like I said, is now taking over? How many dollars or how much money is being spent on the homeless population? The 1.7 additional money is being added to what component of the budget? With respect to the substance abuse budget component, same questions as to what I asked. On the equity and inclusion training that you talked about on one of the last pages. One of the things that we have found over the 50 years or 40 years that I've been working in this arena is that you have to first take a look at the population that you're serving so that you can analyze them and look at what profile of a person or a contractor needs to be hired to provide that training that's going to specifically address the needs of the population that we serve. So let me cite an example. When there was Obama made an appointment to the ambassador to Mexico, and he appointed a Puerto Riqueño. That doesn't fit. It doesn't fit or match the population of Travis County that we're serving. I just want to make sure we take that into consideration. Okay, and one last thing. It looks like there's about 6.8 million. I saw that total is being spent in these areas. And with respect to the business cases, I have asked for that before. So I would like to see a listing of what are the business cases and how are they expected to lower or eliminate disparities and increase the services and the quality of such to our population. I'll write this stuff separately and I'll send it in.
Thank you.
Appreciate it.
All right, Manager Musaitis.
Thank you, Chair. Thank you to everyone who presented this evening. Thank you for your transparency and for having a great, thorough presentation. I personally commend you on all your efforts. And I'm glad that we're going down to a lower tax rate. That is great that you're able to. And again, your efforts are well, again, I don't have the words really to thank you so much for your time. And I hope you can rest for the next couple of weeks before our next meeting. But again, thanks so much.
Thank you. Managers, other questions? Okay, I'm not seeing others at this time. Yes, Mike, Mr. Giesland, yes.
Manager Motwani had his hand raised.
Thank you, Manager Motwani, thank you. Please shout out if I don't see you.
Yeah, we'll do. Forgive it's not a question. I just wanted to also echo applause for the award that's been now received 2 years consecutively. I think this finance and budgeting team does an extremely brilliant job in the short time that I've seen of modeling, forecasting around some extremely unwieldy figures and continuously refining and managing expectations and communicating it in manifold languages to all of us. and striving for continuous improvements is as good as I've ever seen. And thinking about the magnitude of the numbers and the shifting of the kind of variables we're looking at, certainly laudable. I think there's much more to discuss budgetarily, and as we can get more granular. But for now, I just really wanted to echo the applause with relation to those awards.
Thank you. And yes, thank you all for pointing out the awards. It's not easy to achieve, and we are very proud of our staff and their continued excellence. And yes, we will be getting much more into the weeds over the following meetings with the budget. And yes, we do hope that our staff can get a little rest. We've accelerated some things into June, but I'm hoping that will allow our staff to get a little of the rest that they so much need. Manager Valadez, did you have your hand up?
Just one last thing that struck me at the last meeting that I think I put in the paper, but we're going to have a huge like we're spending about 150 some odd $million less in healthcare delivery services. We're going to have an increase to the tune of at least 100 million plus, 200 million plus in the 200 million plus in the contingency fund category. And we're going to have, and I would like to know where we're going with that. What are we spending that on, if not more health services? Because we've got, like I said, we all know we've got almost 200,000 uninsured in Travis County, and we have, but it really doesn't make a difference. As far as I'm concerned, we need to really look at providing services to our population, and our population is the uninsured, underinsured,
yes,
indigent population, and working poor. And if we need to change our eligibility requirements, we need to consider changing our eligibility requirements and look at those dollars instead of storing away money. We spend it on healthcare delivery. That's how we show that we're taking into consideration the needs of our population.
Yes,
thank you.
We want to deliver, I concur, as much healthcare as possible. And I know that staff will be getting back to us under those with responses to those very good questions. Other members, other questions? Okay, if none, then yes, sorry, Manager Jones. Yes, that's what you need to do. Shout out if I miss you.
That's okay. I hit it late. I know as we go into August, and this is our last meeting before August, and once we get into the budget process, I'd like us to consider some kind of parameters in terms of time for board members to have dialogue. I think it goes back to my earlier question in terms of respect for time of each folks. So I don't know if Mr. Duncan can give us any recommendations or best practices on how we might be able to facilitate that. I don't want to eliminate discussion, but I don't think I want to have us to rehash things over and over and over and over again.
So Manager Jones, I have had some discussions with staff on this, and we will circle back on that. Now that we've finished with Dr. Duffer and signed the commitments, I think that what we can, one way to go about this, to be respectful to everyone, is to have some time assigned for each item, and then how much, if each member would like time, how much they're going to get within that item, so that we can be respectful. But I hear your concerns. We've been discussing it, and we will circle back. Does that would that be helpful, Manager Jones?
That's exactly what I'm talking about.
Okay.
If we can put those parameters, I think we will. Very helpful.
Yes, we have had discussions. We will look to that for August, Manager Jones.
All right, thank you.
Okay, Manager Valadez, yes. You're on mute, Manager Valadez.
One of my big, huge concerns is that we are just looking at our 22 budget and analyzing it and discussing it. And I'm here to enlighten the public, just like our Central Health staff is. And if we have questions as a board, we should be allowed to ask them, even if it's in a written form, but expect answers. And if we have written questions that we have submitted, like we were asked to, if we can put those also on our Central Health website with respect to the budget so that the public can see them. Thank you.
Okay, thank you, Manager Valdez. We'll look at how those questions can be visible. Thank you. Members, anything else?
I appreciate that. Thank you.
Anything else, members? Okay, scanning. If I miss you, please do shout out. I'm trying to look at all the squares. All right, I'm not seeing or hearing anything else. I do know that we have 2 items to come back to that were pulled through consent, C3 and C4. Is that correct, Mr. Duncan?
Yes, ma'am.
Okay, well, let's turn back then to C3 quickly. Accept the preliminary May 2021 financial statements for Central Health and the Community Care Collaborative, including fiscal and related operational updates for community care health centers and Sendero Health Plans, Inc. Mr. Giesland, is there anything to summarize here? Manager Valdez, do you have a question here?
Yes, on item number 3.
Yes.
With respect to the budget again, the CH budget had excess on page 6. I think it was what we had received last meeting. Page 6. I just wanted to note the excess sources. It's a $313 million excess. And do we expect that surplus to grow? On the CUC financials, there's the one page which I brought up earlier. I'm not going to repeat myself. I just want to make sure that we can get more updated information.
Okay.
With respect to the CCC budget, the revenue was stated at only at $12 million, but it says uses are $16 million, leaving a deficit of $4.7 million. And I don't see anywhere about the $35 million that we're supposed to be paying Dell Medical. So how are we going to take care of that? That's okay. Item number 3. And I'd like to have those answers.
Wait. We got to finish this item, okay?
No, I was just saying I'd like to have the answers before I can vote on that. Otherwise, just make a motion and.
Yeah, I don't know that we. Mr. Giesland, did you have anything? The 35 million I know is covered elsewhere. Mr. Giesland, did you want to address any of this, or Lisa or Jeff?
Yes. Can we take each question one at a time and just simply, state the question, and then let's see if we can get those answered this evening.
I was just trying to read quickly. Thank you. Okay. First of all, with respect to the whopping $313 million excess, do we expect this surplus to grow?
Okay, that's question 1. Anybody who can address that?
Yeah, I'll start it up. So, yeah, thank you. Yeah, so if you look at our reserve projections over time, and just think about our revenue and spend cycles. So on the revenue side, we collect property taxes. Right. It's 90+% of our revenue. It all comes in, more or less at the end of January. So we're at our high peak. We probably were really more at our high peak around February, March area. That will start to go down this year. In addition to that, in subsequent years, remember the Desert program goes away. And so we've been planning long-term to have a tax rate to sustain our services and create the necessary reserves, but we're looking at it over a 7-year period. And so we're really, when you look at that let me say it this way, since Desert is going away next year, we will be at our high point as it relates to reserves, but those reserves will start decreasing over time as we transition the cost over from the CCC. And of course, the planning that we did long-term was that Central Health would assume those costs. So I think the short answer to it is over a period of time, we don't expect it to increase substantially given the projections that we have over a long term.
Thank you. Question number 2, Manager Valadez.
Just a follow up to that, Jeff. With respect to DSRIP, we were always told the DSRIP projects were created so that we could look at the outcomes and incorporate any changes in practices or policies to how we conduct how we provide our healthcare services delivery system. Okay, so if they've been incorporated, if those benefits, if those outcomes have been incorporated into the system, then why would we need to continue to fund for a project that's been incorporated into our timeline, into our process?
We would still, Manager Valdez, it was, if the outcomes were positive,
that's right.
Then the notion was that we would take it over, but there would be costs for it.
Right. Yeah, we will no longer be paid for them like we are currently.
Right. That's right. That's why I had asked in the past and not, yeah, Jeff, that's why I had asked for in the past and not received exactly on each one of our projects, and there were 30 some odd projects. How have those outcomes been incorporated? Okay, I have asked that, not received it. So
let's submit that.
I think Manager Valdez, I think we have a DSRIP presentation coming up.
I'd like to address.
Perfect.
Okay.
That would be perfect. So
okay.
Item
Mike
number 2.
Easlin, did you have something to add here?
No, Jeff actually.
Okay, so we have that coming up. Manager Valdez, did you have another question?
Yes, revenue on the CCC budget is shown to be $12 million. Yet we have, we would end up having, the uses are 60 million, so we'd end up having a $4.7 million deficit.
Okay, who can address that question?
I can, I'll address it. So the primary funding source related to the Community Care Collaborative, and I'm sorry, you're talking about Community Care Collaborative, is that correct? Did I hear that right?
CCC. CCC.
Okay.
Yeah.
So the primary funding source of the CCC is DSRIP. And so we just recently reported DSRIP. You'll hear a very thorough report from Barbara Adams on that. But the bottom line is we only get paid once a year, and we expect that payment to occur in July.
Thank you. So Manager Valdez, we have a DSRIP item coming up. If we could hold DSRIP questions for that.
No problem. The only reason that I asked it, Chairman Greenberg, is because when we saw the budget 2 weeks ago, what it was presented to us is that we still had an issue to deal with from the feds.
Yeah, I understand. Can we move on to the next question? So to me,
those two issues are aligned, and at some point we need to have a conversation about them. That's what I'm asking.
Move on to is there another question, Manager Valdez?
No, because I took away the second original.
Thank you.
Thank you.
Any other discussion on agenda item 3? We do need a motion on that. Okay, is there a motion?
Chair Greenberg.
Yes.
I move a motion.
Or you could just move approval of item C3.
Yeah, just move approval of C3.
Oh, move approval of item C3.
Is there a second? Manager Saitev has a second. All in favor? Aye.
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 Opposed, same sign. Any abstaining? Thank you, members. Yes.
I'm abstaining.
Okay, show Manager Valdez is abstaining, please. Thank you, members.
Pending responses. Thank you.
Thank you, Manager Valdez. Understood.
C4.
Yeah, I have to read the item. We are now moving to agenda item number C4, accept a grant award from the Episcopal Health Foundation in an amount not to exceed $600,000 for the purpose of funding a community healthcare needs assessment for the low-income population in Travis County, extensive community engagement, and the development of proposed equity-focused strategic service delivery plan. Managers, I remind you that this is not the contract. A related contract will be before the board most likely in August. Manager Valdez, did you have a question?
Yes, I did. We have spent millions of dollars on previous integrated system redesigns. And I don't know what happened there that we have to redesign. Did it?
Question here, Manager Valdez?
The question is, what have we done previously when we have spent millions of dollars on the integrated delivery redesign, and how is it that we need to, I'm sorry, and And are we at Central Health moving in the position or in the process of delivering healthcare services ourselves? And so if so, is that going to be, is that our shift in our Central Health role? And if so, what is that shift and why is it?
Okay, thank you. Mr. Giesland, please.
Yes, thank you for the question, for recognizing me. Manager Valdez, I'm answering this question on the assumption that this information is necessary for you to make an informed decision as to whether or not to accept the grant, which is the only action item that we're asking the board on under agenda item C4, and that is acceptance of the grant. So I'll answer that in reverse. Are we going to start doing this ourselves? That is a great question, and one that is part of this systems-based work, and whether or not it will be answered in this first round of evaluation, or if it's going to be a more iterative. And as we go along, you've already seen some presentations tonight about activities that we have taken on within Central Health, and that will continue to evolve. But I think it would be premature for me to say, especially because ultimately these are decisions that would need board authorization to say, yes, we're going to start standing up a practice line. That's one of the reasons for doing this study, to make sure that we understand the gaps and then look at the most efficient and effective way to address those gaps in healthcare that are creating the health disparities or perhaps exacerbating those. Getting to your first point about the integrated delivery system, I think that's this grant. And then if the board approves the contract in August for the evaluation, it's not going to look back and do an assessment of the integrated delivery system. Now, I might stand corrected on that, because I'm not saying that it's not ever going to come back and reference it, but to come back and do a full-blown assessment from, you know, whenever that was, 2012, somebody correct me on this, through present time.
It was while I have been on the board.
Yeah.
Because we had a presentation, and then I remember Seton coming to us telling us that they were also going to be working on an integrated delivery system. And when I asked them, well, are you doing what we're already doing? And nobody could respond.
You're muted, Sharon.
And whenever you look at, Manager Valdez, the changes in the federal funding, and I'm not saying that this is the only watershed event, there were others certainly, but when you look at the changes in funding that occurred 2 fiscal years ago, and I'll remind the board of this, that was substantial, because a lot of the things that had been thought and planned around the IDS, integrated delivery system, now all of a sudden were shifted. Because the funding arrangement that was previously contemplated for the Community Care Collaborative had to change. And so I think, you know, as we're moving forward, that we have to recognize that there are some things on the IDS that were very successful, some of which you've seen here today in terms of the building blocks that we're able to stand on. But then some elements of the IDS, because of the abrupt changes in federal funding, had to change, had to shift. And we may have not gotten to them in the way that we would have originally contemplated. Now, I'm answering this at a very high level. I know that's probably, quite frankly, other subject matter experts that we need to bring to the table, some of which aren't here this evening, to the extent that this informs your vote on whether or not to accept the grant.
Thank you. Manager Musaitif?
Yes, Chair. I would hope if we can move forward. We have another hour and a half, and we all have to be up early in the morning.
Yes. So is there a motion? Do you want to move approval of this item, Manager Musaitif?
Yes. Yeah,
okay.
I second.
Okay. So we have a motion by Manager Musaitif, a second by Manager Bell. All in favor, say aye. Aye. Any opposed, same sign.
Abstain.
Any abstaining? Okay, show Manager Valadez abstaining. Thank you, members. We will now move to item number 5. Receive and discuss updates on the Central Health Enterprises responses to the current COVID-19 pandemic, including basic reports on services, coordination, and outreach with and among Central Health, Community Care, and Sendero Health Plans, Inc. And I thank you for the email information that we have received. We have a team presenting on this. I will turn it over to them, and we will not entertain questions till they are finished. And I think they will be able, between what you was emailed and the presentation, to cover everything. Thank you, members.
Thank you. Madam Chair, I'll kick it off and then we'll hand it over, and I'll ask each presenter to hand it over to the next one, but it'll go in this order: Central Health, Community Care, and Sendero Health Plans.
Thank you.
So we'll provide a comprehensive update on the three entities. Where we are right now is, let's go to the next slide, please, on the community vaccination goals. Next slide. Thank you very much. So the idea is to get to 70% of the eligible population with the first dose by July 4th. That is very aggressive, but we're putting, I would say, as a different community and governmental and non-governmental organizations, different community groups, or I think putting everything that they've got into trying to get to that point, and then followed up with a vaccination rate of 70% by September 1. Now, what's critical about this is that we reach those hard to reach populations in high-risk zip codes where you've had a disproportionate impact, be it measured in hospitalization or death rates or infection rates by COVID, that have affected predominantly communities of color in a much more adverse way. So again, we're aiming for 70% in those high-risk zip codes. It's not just an overall county-wide average. Now, go to the next slide, please. Thank you very much. So I'm going to combine slides 4 and 5 in a quick discussion, but what this does is it illustrates some of the tools that Austin Public Health and others have put together to help us measure how we're doing. This first slide here that's in the blue with the purple shading, that's a 50% dose distribution in each zip code, again, focusing, you know, if you look in the eastern portion of the county, some of the high-risk zip codes where there's much improvement needs to be done. The second slide that follows this one, that has the blue, green, yellow, and red colors, is a 70% distribution within each zip code by July 4th. So again, one's 50%, one's 70%. This provides a much more granular look at the distribution. Now, and again, these are just designed to show, you know, some of the tools that, again, APH and others have produced. So I want to give credit to those other organizations that have done this, and also with a lot of input from community groups about understanding the dynamics in the different zip codes and the much different populations. These numbers that you see here are obviously out of date. I mean, again, this is, you know, what we had at the time that the packet was put together, but it changes quickly. And so, for instance, if you vaccinate, could be as few as 75 people, you can take one of these zip codes and you can flip it, you know, from a 50 to a 60% or to a 60% to a 70%. And so that's the kind of margins that we're talking about. But I think that it validates the different approaches that everybody is taking, which is to have very concentrated outreach, like with our Stick Together campaign that was launched this week with multiple partners, but also our equity incentive payments that we have with the FQHCs to reach high impact zip codes as measured by social vulnerability index scores, and which again are predominantly communities of color and those that have been adversely affected by the COVID pandemic. But it also shows that other partners like Community Care, Austin Public Health, a lot of the community groups that are not governmental organizations that are helping to organize events, for example, like the Austin Latino Coalition and others, Del Med School, that actually that would be on the government side, but what it shows is that the mobile strategies and the quick pivots that are necessary to be able to address some of these underrepresented areas are absolutely critical. So moving away from the mass vaccine sites to a more agile strategy, again, is more than warranted and justified in terms of how we're helping to support those efforts. Lastly, before I turn it over to Ted and Ivan Davila to cover the communications update, I would like to note that we're also providing, in addition to the equity incentive payments to the federally qualified health centers, working with organizations to provide incentives. And you've seen the incentive cards that we talked about in our media release and t-shirts. And I want to give credit to Elizabeth Madero for helping us coordinate a lot of this distribution. Ted and Ivan.
Thank you, Mike. Next slide, thanks. Central Health led an effort to create a unified vaccine campaign for about the past 6 weeks. We've been partnering with Austin Public Health, Travis County, and Community Care. You see the campaign brand on the screen there. It's called Let's Stick Together. And this initiative aims to achieve, as Mike mentioned, the community-focused goal of 70% first doses by this weekend, July 4th. APH reported a couple of days ago that we are above 69%. However, as Mike mentioned, we're also focused on zip codes and communities where vaccine rates are lagging, and in some cases still below 50%, that's 50. The main campaign message for this Let's Stick Together initiative is we've all been doing our part to protect ourselves and our family and our community from COVID-19. For more than a year, we've stayed home, worn masks, and missed out on a number of important life events. So let's stick together, which means let's get vaccinated, but also let's stay unified so we can all get together again soon. And there are many supporting message points, including messages that address fears and hesitancies that really have remained pretty consistent throughout the pandemic. Fears about whether the vaccine is safe, fears about the side effects, not just getting sick, but fears from people who worry that if they get sick, they'll have to miss work and not get paid. The campaign was developed in English and Spanish, and it coincides, as Mike mentioned and Dr. Morgan earlier, with the APH and Travis County adjusting their vaccine strategy from hub to more of the smaller, more nimble pop-up vaccine sites at churches and neighborhood stores, community centers and churches in these high-risk zip codes. And as I mentioned, as Mike mentioned, areas where vaccine rates still aren't at 50%. Now I want to invite my colleague, Ivan Davila, to talk about the co-creation of this campaign in Spanish, and he was instrumental in that and why we believe it works well. Ivan?
Thank you, Ted. So our target population for the Spanish language of the campaign is first generation monolingual Spanish speakers with low income. We developed the Spanish language version of the campaign with 3 Spanish language communications experts, including our colleagues at Cultural Strategies. And we also worked with our consultants at Latino Healthcare Forum. With support from Cultural Strategies, we went beyond a simple translation and we transcreated the Spanish version of the campaign. Transcreation differs from simple translation in that it communicates concepts in a different language while maintaining the spirit of the message, keeping its true meaning and intent, even if it means completely rewriting it and not leaving a single word of the original language version. Having said that, as Ted mentioned, let's stick together with 2 meanings. One is get vaccinated and let's stay unified. We went around with and we analyzed and evaluated about 15 different concepts in Spanish and in English. And finally, we arrived at 2 words in Spanish that say specifically exactly that. One is vacunémonos, let's get vaccinated. The other one is juntémonos, let's get together, let's hang out. Juntarse in Latin America is slang for let's hang out. And so those were the 2 words that were chosen so that we could capture the essence of the campaign, and it could go well together with the campaign in English in a way that conveys, again, we can all get together if we get vaccinated. Ted?
Thank you, Yvonne. We worked with our consultants, including Belmont Ice House and Cultural Strategies, to produce a toolkit with a variety of creative assets for our partners to use. And you can see some of these assets on the screen. This campaign was developed so that our many partners, and I'll talk about that in a minute, can adapt this and use this at no cost. We want them to use it any way they can, whether it's in paid media, social media, through their own owned channels. We are encouraging that.
And as Yvonne mentioned, we work with our consultants, Latino Healthcare Forum and Community Coalition for Health, just to make sure the messaging resonated and that the campaign call to action made sense. And we couldn't do it without our trusted consultants, making sure this works with residents. So again, you can see some of the examples here on the screen. It's also designed to be geo-targeted by neighborhood. So you might see a different campaign in Hornsey Bend or Del Valle versus Colony Park or Pflugerville. Next slide, please. This is the part that I'm really proud of and excited about, was just how many partners have come together and to sign on to this. It's not an easy feat to bring so many people together and to reach consensus through very passionate collaboration. But I think we've done that, and we're not done. We're not limiting the number of organizations, and I am positive there are some that we've not heard from or reached out to or contacted. Well, I might take that back. We did reach out and send a pretty robust, comprehensive email to our campaign partners. So far, 20 have signed on. You can see them there on your screen. Again, no requirement other than they just help us amplify the message, whether it's at outreach events, through community engagement, paid media, social media, et cetera. And Central Health and APH are placing paid media. APH does sort of a broad media campaign, while we're focusing on 8 or so zip codes, the ones that Mike mentioned, where vaccine rates are lagging. So we're really going after the uninsured, people with low income, and our MAP population. There'll be radio, TV, digital, paid social, print ads. And then, as I mentioned, hopefully all of our partners will push out this information on their owned channels. And there was a joint press release that went out Monday. Hopefully you saw some of the media coverage. It got a lot of great exposure, which is exciting, both in English and in Spanish. And then I'll let Yvonne talk about some of our outreach efforts that we hope this campaign will be incorporated into.
Thank you, Ted. We are working with the Central Texas Vaccine Collaborative, who is diligently working on standing up pop-up vaccine sites, currently at 4 different JD supermarkets across Eastern Travis County. And we are working with them, exploring how they can actually use the creative assets of this campaign in their promotional materials. And we're also working with them, providing staff capacity as well at these events. And we're working with our our partners, Community Coalition for Health and Latino Healthcare Forum, to identify additional locations for these pop-up events throughout Eastern Travis County and Southeast Travis County as well as Pflugerville, some of the high priority zip codes that we've been hearing about during this evening's presentation. We're also providing incentives to motivate people to get the vaccine throughout these pop-up distribution or vaccine events. And we're also going to be going back to the same small businesses, apartment complexes, and faith-based centers who partnered with us last year during the Protect Yourself, Protect Your Family campaign. And we're going to be taking posters like the one Ted showed on the previous screen, the Let's Stick Together posters, so that they can also display them in their facilities.
Thank you, Yvonne. And that's all for our presentation on the Unified Vaccine Campaign.
Very well. And so we'll hand it off to Community Care. And but before we do that, as they're queuing up slides and getting ready to present, just from a personal standpoint, but also professional, just wanted to thank everybody within the Community Care universe. It has just been amazing to work with them and to think about the numbers of vaccines administered in Travis County and the tests and the amplified outreach and the connections with served patient populations. It would not have been possible to achieve the results to try to protect people from this virus and to mitigate the impact that a global pandemic has on people. So those words are not sufficient, even if we could go on, but at this point I'll turn it over to Jason to provide their portion of the presentation. Thank you.
Great, thanks so much, Mike, and good evening, Board of Managers. I'm assuming you can hear me, otherwise I'd be hearing otherwise, right? Okay, thanks Cynthia for the nod. It's a pleasure to be with you here this evening, Board of Managers and Chairperson Greenberg. Thank you so much for the opportunity to highlight the work that we've done, not just at Community Care, but with so many partners, our friends and colleagues over at Central Health. As we all know, this has been a community-wide effort. It still needs to continue to be a community-wide effort, but it's my distinct pleasure to represent the board.
Jason, you're fading in and out. I don't know if you have earbuds in or if you need to get closer to the mic.
Is that a little bit better or no?
It's a little bit better.
Yeah, I'm going to get right up on the screen. Apologies.
I think that's what you need.
Okay, apologies. So as I was saying, it's, you know, it's not just community care. There's so many partners that have been involved, inclusive of our colleagues and friends at Central Health. As we know, this is such an important community initiative. And I get this evening to represent the work of literally hundreds of folks within community care, and across not just community care, but within the Central Texas COVID-19 vaccine collaborative, which operated at CODA, and then also at the Expo Center. And as Yvonne had indicated, now is doing pop-up events in Travis County. So I'm going to take a deep dive into our data at Community Care. And it's going to be twofold, just teeing this up. It's going to be our patients, those that we've actually vaccinated, the vast majority, or folks that we have knowledge that they've been vaccinated, which is a much smaller number. They've gone somewhere else. We're not always getting the information back. So the way that we're capturing it is when we see them in a visit for the most part, and we're actually populating our systems. And then additional to that is where we were the vaccinator of record, both at the Circuit of the Americas event, as well as at Expo. I'm going to advance to the next slide here. Sorry about that. So to date, as of June 24th, we have provided almost 118,500 unique doses of COVID-19 vaccine. So both Pfizer, Moderna, as well as a little bit of Johnson & Johnson. What you're seeing in orange is all vaccines that we've provided, either through CODA, Expo Center, or at our clinics. And additional to that in blue is the total number of doses that we've provided, sitting over here on the far left, as it relates to in blue within community care's direct health centers. What you're seeing here in the middle is total first dose, so 63,804 units. Look over here, we've got in community care.
I think you're really going to have to stay right on that mic. You're fading in and out. I don't know, again, if you have earbuds in or what, but you're going to have to stay right on that.
Yeah, apologies, Manager Greenberg. I don't have earbuds in, so it must be a mic issue with my computer, so apologies. I'm going to stay right up on it. So this column here in blue is the unduplicated first dose individuals that we've done, and then the total number of individuals completed their vaccine. So this is first plus second dose. So complete vaccine, 4,686 within 22,000.
Jason, I'm sorry, we really can't understand you. I don't know what's going on. Is there somebody else maybe with a different laptop who could take this over? We're going to have to proceed.
He might, Jason, maybe you can try calling in so we can hear you by voice.
Because we're going to have to proceed through this.
This is Mary Jennings. I was in miscommunication with the staff, but I am available to pick up where Jason left off if he isn't able to connect back in. My apologies for the miscommunication and being a little off time.
Look, technology is a blessing and a curse. So if Jason cannot, why don't you go ahead, Mary, and just proceed until Jason can get on, because we do have some other items to get through.
So Jason will have to stop sharing.
Wait,
Jason,
time out. Can we do a quick sound check? Jason, can you hear us
Jason,
okay?
are you on? Jason, you're on mute. We can't hear you on the phone.
He's not on the.
Can you hear me now?
Yes, but you got to get off the.
Well, he's got to have a way to be able to drive the slides.
Yeah,
So.
but feedback could be. Jason, let's give it a try quickly, please.
Yeah, sure.
I'm
getting that awful feedback.
You're probably going to need to turn down the speakers on your computer.
Exactly.
It's already done. Okay, can you hear me fine now, Manager Greenberg?
Yes, we can hear you. If you can go ahead and just.
Yep, I'll proceed. Apologies.
No worries.
So on this particular slide, then what we're taking a look at is the percent of individuals vaccinated in orange across all sites where we were the vaccinator of record, including CODA and then Expo and then all of our sites. So you can see 45.1% of folks that we vaccinated at 118,000 individuals we were talking about. 41.1%, 45.1% were Latino, and then in community care sites, significantly higher at almost 64%. And then when we come across, you can see the percentages for non-Latino and then unreported ethnicity on the far right. So kind of breaking this down by race, with white reported with ethnicity. So towards the right-hand side, you'll see white Latino, white non-Latino, and then white unreported, and then all other racial groups reported. In the orange, again, what we're looking at is all of the sites where we were the vaccinator of record, which is inclusive of CODA, the Expo Center. Of those total 118,000, or the 63,804 unique individuals vaccinated, what we saw was 67.3% of folks that we were the vaccinator of record were self-reported as being from a minority population or a community of color. For community care patients vaccinated, again, represented in the blue columns, what you're seeing there is that 83.5% of the folks that we vaccinated within our health centers were drawn from a minority community. So a very high percentage of individuals that we've been vaccinating and continue to vaccinate within the clinics representative, not only of our communities of color here within Travis County and surrounding areas, but also very similar to what we see as our patient population, which is about 84% or so communities of color. So looking at unique individuals by language, you can see that within our environments, we had almost 50% of the folks that we have gone ahead and vaccinated within community care's environment spoke Spanish as their primary language or preferred language of service, comparative to what we saw across all the sites, inclusive of CODA, as well as the Expo Center. That was about 27.4%. But again, very representative of a diverse population. You can see other languages as well. The languages are numbering close to 70 individuals that we have had vaccinated coming and being served in a language other than English or Spanish. So when we break it up by age range, again, what we're seeing within community care's environment, we're actually getting within our health centers a higher or older population vaccinated, and we targeted our older individuals first 65 plus and then 50 plus. But again, when we look across what the work was done with our partners through the Central Texas COVID-19 Vaccine Collaborative, 41.2% of individuals were above the age of 50. And a lot of that started changing, especially towards the end of those large mass vaccination clinics when it really started opening up and we weren't having as much demand. We saw the younger individuals, and of course, we started targeting the 12 plus as well once Pfizer opened up to being able to go ahead and vaccinate. Relative to uninsured, this is fairly dramatic in terms of the number of individuals vaccinated. What you're seeing down here are unique individuals. And so we had 58,416 unique individuals who self-reported as being uninsured or did not report their insurance. And then you can see the breakout across, and then you can see community care patients. Again, reminding that we had 26,627 unique individuals in community care's environments that have been vaccinated.
23,000 or almost 89% were uninsured. And so again, a very high proportion of individuals that we vaccinated within the health centers that we operate in partnership with Central Health were uninsured. So this, I'm not going to go line by line, but this is just for reference. Yeah, Chairperson Greenberg. But this is so you can see the top 15 zip codes that we vaccinated. And this was inclusive of the COVID-19 collaborative that I've mentioned already with Travis County, Hayes County, Caldwell, and Bastrop County, as well as Ascension-Seton, and inclusive of our own patients at community care that we've done within. And so when we take a look at the top 15, 54% of all those that came through those various different sites were drawn through from these 15 top zip codes. And you can see number one is Dove Springs, 78744. Number two is 78753 Runberg. By the way, in all of our data from the positivity rates and testing that we did throughout the last 14 plus months, those were the two zip codes with the highest level of positivity rates. So it demonstrates that the work that was done as part of the collaborative and within community care, thanks to the work of hundreds of our employees within community care, our clinicians and nurses, so many that were involved, we were getting to the highest risk communities, but still much work still needs to be done. And then it's broken out by percent of penetration into the total population, the low income population. The next one similarly is just community care only patients. And what you'll note with this is the vast majority of the top 15 are all Eastern facing zip codes within Travis County. And that's going to be best demonstrated in the next subsequent slides where there's geocoding of all the unique individuals vaccinated. That's what you're seeing on this. So this is using ArcGIS. And what you're seeing here is a heat map, and it demonstrates anything that's in bright yellow has a higher concentration of areas where folks have been vaccinated from community care as the vaccinator of record. And this is inclusive of CODA and the Expo Center. And so you'll see as I get to the community care only patients, you'll see it even demonstrates greater penetration into Eastern Travis County. But just kind of following I-35 all the way down here, you can see I-35 coming all the way down. And even with this, it's kind of split along I-35 overall. Here's with community care with just the collaborative itself. So this is a collaborative not with community care patients in. And so you can see, again, widely dispersed. When I flip to community care, where there's the 26,267 patients, you can really see that who we got to through the health centers, through Rosewood, Zaragoza, through our Burleson Mass Immunization Clinic is now, as well as up in Pflugerville, is we're getting to those highest risk zip codes. So Dove Springs down here, 78744. You're looking at Riverside and Montopolis, 78741. Sitting down in Del Valley, 78617, 78725, 78724, and then up here, of course, Runberg and St. John's. And then you can see coming up along. So this really matches what we were trying to do with support from Central Health and others, is to make sure that the vaccines we had available very early on were being directed towards the communities that were not only the most underserved, but also, as we've unfortunately learned throughout the pandemic, the communities that were most dramatically impacted by the coronavirus, both from an adverse health outcome and from a mortality and from a positivity rate as well. And this is getting, like, underlaying those heat maps are little dots of every vaccine. So what you're looking at here is a dot for every patient. This is at a high enough level where you can identify individual addresses, but every dot on this map represents one of the doses that has been provided through June 24th of 2021. And so you can see, again, concentration in the Dove Springs, Del Valley. This just kind of demonstrates those heat maps just a little bit more for you as Central Health Board of Managers, just so that you have an idea of what's going on. And then flipping to this, because it was part of the collaborative, and I know this is kind of distorted a little bit, it's really, if you pay more attention to what's going on the right-hand side, because we were partnered with Hayes County, Caldwell, Bastrop, and Travis County, you do see concentrations, especially as we take a look at the work that was through CODA, sitting down in Caldwell, also in Hayes, and then also in Bastrop. Unfortunately, Williamson was not part of the collaborative, but they definitely benefit as residents that were served not only through the collaborative, but also we have patients that come from Williamson County
And that's the scale and the slide to the right actually demonstrates that. So just a very quick update in terms of where we're at now. We're still, of course, providing vaccines each and every day. We're operating in a Rosewood, Zaragoza. It's a walk-in, drop-in, don't have to be a community care patient. Same thing in Pflugerville. We are also in Manor on Wednesdays every week, and then occasionally on Saturdays. We are not only providing one gift card, but thanks to President Biden's administration and a partnership with DoorDash, we also received through Direct Relief gift cards in $25 increments for DoorDash. So we're coupling the HEB gift cards in $25 that were received that we're purchasing directly at Community Care as an incentive for folks to get a COVID-19 vaccine with the DoorDash. And so folks are eligible for that. What you're looking at here is the trends over the last couple of weeks. So it's maintaining pretty steady. The week of June 6, 869 total vaccines administered. June 13th, it's 810. This was pulled from a week ago. Then you can see the schedules that were where the appointments were. So there is some demand, but I think the work that was highlighted by Ted and Yvonne is so critically important to get to the folks who are hesitant, that just need that little extra nudge to go ahead and get the vaccine itself. Epic's up there because these are new reports that have our new electronic health record system that, because we weren't busy enough throughout the pandemic, we decided to switch to electronic health record system. And we actually went live with Epic on March 27th. So we've got some pretty robust data that's coming through that way. Just a little bit of information that I've already covered, Madam Chair, and that concludes Community Care's presentation for this evening. Thank you so much for the opportunity, and apologies on the audio.
No worries. As I said, technology, it's a blessing and a curse.
Agreed. Thank you so much, ma'am.
Okay, at this time, Dr. Jennings, I believe you're next.
Are my slides showing like just the corner? Can people see them fully?
I can see them.
We have full vision.
All right, thanks. Just a sec. All right, so thanks for inviting me to present on behalf of Sendero today. So as hospitals filled up and public places shut down, Sendero initiated a registry of COVID-19 diagnoses that were reported to our case management team and also gleaned from claims. And that's a picture kind of to date of the raw numbers that we've captured. We took that approach to just capture raw numbers, mirroring the approach that Austin Public Health and state dashboards have used to just present a kind of real-time picture of our COVID burden. And this, of course, this bimodal curve that peaked in July and also in January mirrors the local disease burden peaks that you are quite familiar with in and around Travis County. The orange here represents COVID cases among our non-CHAP expansion members, and the blue cases show cases among the much smaller but much more medically socially complex CHAP expansion populations. And just in general, these simple case counts don't really allow much for synthesis or analysis. The presentation that I'm following, we've got a much smaller piece of the picture to present, but their purpose is simply to trend the population disease burden that our membership has experienced over time. Next slide, please. So Sendero, in effect, seconded staff from our member services team to staff central health and community care, community outreach efforts to educate and promote COVID-19 safety. Through, next slide, please. Throughout summer 2020, I'll just speak to kind of the highlights here. Our team supported central health-wide initiatives to distribute COVID prevention kits, essentially to locally owned businesses. You'll see kind of these green pieces. We also mailed 12,000 COVID care kits to our members. And then from January through May 2021, our staff worked on site to support the patient intake process that you've just been hearing about from my colleague Jason at the Rosewood, Zaragoza, and Coda mass vaccination clinics. We just put this in context here, right after right after WHO had declared the pandemic, we had started outreach, and I'll come to that in a minute. So also like looking at kind of where our first health workers were vaccinated, or the US's first health workers are vaccinated in January. So those points along the top are kind of global, national time points, and we've tried to just demonstrate the timing of our own efforts along the bottom there. So we have a team of 8 community health workers who serve as care system navigators and patient advocates for our CHAP members, and also our CHAP expansion members and our other high-risk members who are active in case management at Sendero. And of course, at the end of December 2020, Operation Warp Speed had culminated in the first health workers getting vaccinated, as I was mentioning. And within the week, as of January 8th, our CHWs, our community health workers, started COVID vaccine outreach efforts to our CHAP population, initially scheduling just in that first couple of days, 154 members for first dose appointments on July 11th at the Delco, then it was Delco Mass Vac site. So 1 in every 2 of our members see a PCP, a primary care provider, in the community care network. And we referred our CUC patients to be scheduled for some of those Rosewood Zaragoza appointments. Once we had attempted or established contact to schedule each of our highest risk members, we expanded vaccine appointment outreach to a smaller group of otherwise healthy members over age 65. Again, for Sendero, most community members, most of our members will transition to Medicare at 65, but some are not eligible. So we have a small population meeting that criteria. Overall, our CHW team made up to 3 attempts to contact members to schedule them for a vaccination appointment. And through our standing contract with Lyft, we provided rides to appointments for members who were experiencing a social determinant of lack of access to personal transportation. And as I'll show in more detail briefly on my next slide, we were able to contact and to schedule appointments don't go to the next slide yet. I'm just referencing the slide. Thank you. to 56% of members over 65, to roughly 80% of CHAP that we had outreached, and to 17% of regular members under 65 who had at least one comorbidity risk factor for COVID. So let me keep speaking to this slide. On top of these member-oriented efforts from our member services and our case management team, Sendero also undertook a series of community-oriented efforts through our population health team. And those are presented in kind of the blue boxes and the blue arrow here along the bottom. So along with a number of surveys and analytic projects, we undertook an assessment of the role of social determinants of health on vulnerability to COVID and on intent to vaccinate that was implemented in December 2020. And I'll also continue to evaluate a corresponding qualitative assessment of the reasons that local community members have questions about or concerns about, basically you're hesitant about taking a COVID shot. And as many of you will have been involved in or have seen firsthand, many of these findings have been presented, published in the peer-reviewed literature, talked about elsewhere. And we're pleased to report we're able in some small part to inform Austin Public Health planning of education and mobilization efforts, more of which you've heard about earlier in earlier presentations tonight. So 3 months ago in March 10th, Sendero also hosted a community conversation on the equity gap in COVID-19 vaccine coverage with Ms. Stephanie Hayden Howard, who was then director of Austin Public Health, now assistant city manager, as well as Central Health's very own Ms. Cynthia Valadez, and yours truly, among others. And as of this month, just kind of to speak to the high level of what we're looking at, Sendero has initiated a follow-up survey to better understand the relationship between that earlier expressed intent to vaccinate from December and reported behavior vaccine uptake. Just another small effort, we're excited to report that we've opened initial discussions about how Sendero, within its context as part of the Central Health community, can continue to support the local COVID-19 response and core public health efforts with Austin's new top doc, our Austin Public Health Medical Director and Public Health Authority, Dr. Desmar Walks. Next slide, please. Thank you. So in this feel that at Sendero and all across Central Health, we're focused on health outcomes, on the end game for our members, our patients, and especially, as will resonate with all of you, on our neighbors and our community members who have been given less than their fair share of opportunities. So let me close out my brief update with some remarks about what our data allow us to infer and don't allow us to infer on COVID vaccine coverage across our membership. So of course, Sendero has been covering all FDA approved CDC recommended vaccines free of any out-of-pocket, as is standard across the industry at this point, to all of our members since the vaccines were first available. They were added to our formulary as other plans are doing so this January. And I just want to point out there are limitations to our primary data sources. Number one, the number one source is I kind of demonstrating this Venn diagram here, is case management administrative data, which reflect operational records of the outreach efforts that I've just reviewed. And as well, like the second source will be claims-based data, which reflect any vaccination provider who submitted a claim for Sendero to cover the administrative fees for any of our members who they were vaccinating. So these numbers together paint a picture, but they represent an underestimate of true coverage among the community members that we insure. And again, this data is from mid-June when we prepared this report. But they do allow us to say that based on claims, at least 29% of non-CHAP members over 65 received a first dose. Based on administrative records, at least 80 to 81% of these that we had intervened with are fully vaccinated. Our claims, which are imperfect, would show that 32% of our CHAP population had received a first dose. And when we look at the members that picked up the phone after our outreach or that communicated with us, we've got 74% of that population reporting they're fully vaccinated. And then the regular membership under 65, we have about 56% of that in our administrative records. On average, if you're kind of looking at coverage among the members that we outreached across these groups, we can say we have at least 68% coverage, and looking into how to leverage additional information and resources to better understand full coverage among our overall population, given the caveats and limitations of our data sources for these estimates. So take home, this is an underestimate, but quite positive overall in terms of the, what some simple outreach that's persistent and based on relationships with our members can do. As of this morning, the Johns Hopkins vaccine tracker showed 38% of Texans have been fully vaccinated, and local zip codes in and around Travis report fully vaccinated rates between a low of 40%, with most zip codes in the area reporting 60 upwards of 70% fully vaccinated, and that's based on DSHS data and corroborated by Jason's data. So in closing, we've come a long way. We're excited to continue strengthening partnerships across Central Health and the local public health community. And the next slide, please. The next step starts here at home with our own personal decisions to take care of ourselves and in turn our community. Thanks.
Madam Chair, that concludes our presentation. We appreciate the board's time and attention on this matter. Thank you.
Just amazing. Let's have a round of applause, everybody. Virtual, maybe you can hear mine. Just amazing, amazing work. And an overall theme, partnerships and collaboration. Kudos to everyone. Jason, the work that community care did, I don't even have words to express all that you and your staff have done, on the front line. The heat maps were great for visualization, as you said. Amongst all that, the new EPIC system with the data, but just the care that you have provided. Thank you from the bottom of our hearts. And the Let's Stick Together campaign, Ted and Yvonne and all the community partners, again, collaboration. This, I hope, is the beginning of a beautiful relationship that continues among all of these collaborators on this coordinated communication, something that you and I have discussed for a long time. I applaud your leadership in Yvonne's and so many others at Central Health and in all those entities that you listed. Again, the theme of what we can accomplish when we partner and collaborate. And Yvonne, I so appreciate that you said we didn't just translate into Spanish, right? We looked at, you know, how we present this concept in Spanish. I will tell you that the let's stick together with the 2 meetings, I wish that this would be adopted nationally. Okay, really, I think it's just just tremendous. And of course, Sendero, congratulations on your tremendous research. You know, I'm such a research geek, and congratulations on your tremendous research and all the value that you have added with your care, with your data, with your research, with the vaccinations for CHAP. Kudos to everyone. So thank you very much. Really appreciate everyone's hard work. And please extend our thanks to everyone who is not with us here on the screen, but you know, we appreciate all of their hard work. Many people have gone without sleep for many, many months. I'm really surprised that some of you can still talk and walk. I don't know that I would be able to. Thank you very much. Members, I would say if we have any detailed questions, given the time, I would ask that we submit them in writing so that staff can, the various staff members, we had so much presented that can be, you know, go to the proper people and they then have time to evaluate and analyze and respond. Manager Valdez, did you have a question? You're on mute.
Just one. I got everything except objective number 3, the slide that had the bright red. I was a little bit confused with respect to when it talked about the 49.9. The red signified the 49.9% penetration. Of course, that's a much lower penetration than the 70%, which we're targeting for herd immunity. So that I'm assuming that the reason for telling us this is because that's where we need to really, again, focus and renew our.
What's the question here?
I just wanted to clarify because I think I admit that.
You're,
Am I understanding correctly that that's what that is?
Let's see if we can get that clarified for you.
Yes, ma'am. Your understanding is correct. And again, to remind everybody, that's a dated number, but that's one of the many tools that we have to know this is where we need to focus. And
thank you.
I believe Megan's still on the line. She helped design and quarterback all of our response efforts. If she has anything to add.
Thank you.
Well, Megan, I see you now, and thank you for all that you have done for us. You have, for Central Health, really been at the forefront, so thank you.
I just wanted to say one thing to Yvonne, that when they were talking about the let's stick together, I swear to God, I could hear Haley Mills in the background. Maybe that's dating me, but that's what I heard, you know? Let's stick together. Okay, go ahead.
Thank you.
Chair Manager Musaiti.
Manager Jones.
No, I want to thank you all for an excellent presentation. I would encourage us later in the fall to have an updated presentation in which we could have time just to interact and ask questions. I have hundreds of questions I'd like to ask, but obviously we can't do it in this format. It's an excellent presentation, great work. Thank you for your hard, dedicated service, but let's try and give us some time to have some dialogue in the fall with updated information.
Thank you, Manager. I think that's an excellent suggestion, whether it's here or perhaps at Strategic Planning Committee, if we can have something where we can focus on this. But I would say if you have specific questions, any of you, let's submit them in writing so that there were so many staff members of different parts of our enterprise involved so that they can address them. Anyone else have a question at this time before we move on?
Manager Musaiti has a question.
Manager Musaiti, do you have a question?
Well, mine is more of a comment. Thank you all for the thorough presentation. Thank you, Jason. Thank you to the Sendero team, and especially thank you to Megan Cermak for everything that she has done for our community. She's been on call 24/7 during this period of time. I hope that you can rest, and your work is much appreciated. And
thank you.
As a public health person who worked in this, it's not easy, and commend you on all this effort and saving lives. And again, much appreciated to everyone.
Indeed. Thank you, Manju Masaita. Anyone else at this time? Okay, well, we will then let so many staffers who have so much work and I'm sure exhausted take their leave. So thank you to all of you for your excellent presentations. Members, with that, we will move to item number 6, payment paren DSRIP, DSRIP, closed paren program and associated projects, the Community Care Collaborative and other healthcare delivery partners, programs, projects, and arrangements, including agreements with Ascension, Texas. I know we addressed a little bit of this earlier, but said we would come back to anything else that we need to with this specific item number 6. John Morgan and Barbara Adams will be presenting. I will turn it over to them.
Thank you, Chair. John Morgan, Chief Operating Officer. And for this presentation, I should note that I serve in the capacity as the Executive Director of the Community Care Collaborative, which houses our DSRIP program. My comments will be very brief considering the hour and the board's time. I get the privilege of introducing Barbara Adams. Barbara is a Service Delivery Operations Manager on our team, and in addition to overseeing our DSRIP program, she manages our primary care contracted services portfolio and also oversees our project management office, among many other things.
Thank you, Barbara. Welcome.
You all are aware of the complexity of the program and the year-over-year successes. You know, I absolutely have to recognize the monumental efforts of our clinical partners as part of that success. But a large part of that is also due to Barbara's efforts and our DSRIP team here at Central Health. Barbara's going to walk us through a brief update on the current DSRIP program, and then she's going to touch on some of the projects and initiatives and programs from the prior DSRIP program and what has been sustained throughout the years and even to today. I should note that Barbara did not run the DSRIP program at the time of the first round. So she's going to do her best to give us those updates. If we have detailed questions about the first round of DSRIP that ended several years ago, we may have to follow up with you offline after we do a little more research into that initial program.
Certainly understood, and we'll follow
up. I'll turn it to Barbara. Chair, thank you for allowing me the introduction.
Thank you.
Thank you so much, and I appreciate that, John. I'd also like to say I've had a very consistent DSRIP team working with me, and they have been amazing on the Central Health side. So I'd like to recognize them as well. As you recall, this iteration or this DSRIP 2 iteration is a little bit different than the DSRIP 1. In DSRIP 1, it was very project-based, and in DSRIP 2, it's very quality measurement based. And so there are 4 categories that the DSRIP program is divided into. I'm going to start with describing category B because that kind of is the foundation, and then everything sort of builds on that. With category B, we had to identify our DSRIP population, and we identified them as the medical access program population, and count the encounters that they have had in the performance year. And so we had to maintain that number of encounters or increase. And so each year it's been worth 10% of the overall incentive value. Then we go to category C. In category C, we had to select a number of bundles of measures, and if we selected the bundle, we had to perform on all of the measures within that bundle. And we selected 36 measures that are in 7 different bundles. And we have to report each year on our performance for those measures. And we also have to meet the targets that HHSC has provided for us to meet for those based on our baseline. And the population that's included in category C is the category B population. So that's how that builds. Next, we go to category A, and in category A, their HHSC wants us to report on 4 areas: our core activities that we are conducting to improve on our category C measures. They want us to pick an activity that we're doing and do a cost savings analysis on that core activity. They want us to know what we're doing to move forward to a reform payment structure. And then finally, we have to participate in a regional learning collaborative. And although category A is not worth any incentive, we have to perform on category A and report in order to make available the remaining category incentives. Finally, we have category D, and category D has 13 quality measures. We do not have to improve on these, but we do have to report on them each year and include any kind of activities that we do to improve on those areas. And some of them are things like what we're doing to reduce reduce admissions for long-term diabetes complications and short-term diabetes complications. So 13 measures there. All in all, we've started off with the District 2 program in 2018, earning $66.6 million per year. We did that, and it was level in 2019. In 2020, we had it was an expected slight drop, and it dropped by about 6% and down to 62.6. In 2021, we had an additional 13.78% decrease in incentive, with an overall decrease from 2019 to 2021 of about 19.78%. This year's total incentive, available incentives, $53.4 million. Finally, in 2022, there is no more funding under the district program, so all activities end essentially December 31st of this year. Next slide, please. These are all of the measures in our category C, in the category C. As you can see, there's 7 bundles, a total of 36 measures. We set our baseline, which is the first column of numbers. And I realize that this is very small, but hopefully you might be able to print it off and get a better look at it. And the bundles include chronic disease management for diabetes, primary care prevention measures, cancer screenings, adult dental care, hospice care, behavioral health care, and pain management. And I would like to recognize that we could not do the work that we've done without the partnership of Lone Star Circle of Care, Community Care, and Hospice Austin. They have been wonderful throughout these years and have really done amazing work to improve on these measures. And just some highlights of some of the areas that we've done. We've provided over 2,300 more people with the flu vaccine compared to our baseline. We've improved the percent of people reaching remission for depression by almost 275%. And we've screened over 4,600 additional people for alcohol use and provided counseling. The next slide, please. With 2020, calendar year 2020 performance, of course, we all know that COVID came and impacted our world. And so that really had an impact on our ability to achieve those measures. Unfortunately, HHSC worked with CMS to provide some COVID allowances, and we'll go over those here on the next slide, but don't switch yet. But I did wanted to say that that first table on the top there is our 2020 performance. And I apologize, that first bullet has a typo. It should be calendar year 2020 performance. And that is the incentive that we earned overall with the COVID allowances. And so we earned 95.78% of our total allowable incentive, which is great. Our partners really did well during 2020. Conversely, if you look down at the bottom table, you'll see that had we not had those COVID allowances, we would have earned about 86.08% of our total incentive. So to look at what those COVID allowances were, if you could switch to the next slide. For our category B, and remember that was our defined district population that had to have an encounter at a clinic, they allowed for telephone encounters. And then also we they allowed for a variation during normal years, and our variation was 2.76%. We could vary and still earn the full incentive. But for our COVID allowance, they allowed that variation to be 35%. For category C achievement, for each measure, we were able to use whichever one put us in the better position. So we were able to use either the achievement that we had already reported in 2019, we could report again in 2020. We could report our actual 2020 achievement, or we could report the state's average earned incentive for that achievement. For example, 75%, if on average organizations earn 75% of the incentive, then we could claim that state's average of 75%. With regards to the COVID allowances for 2021, HHSC is still considering those and negotiating with CMS. Next slide, please. For our FY22 achievement, we will be submitting that report in April of 2022. This will be our final district submission in April of 2022, and we expect our final payment to be July of 2022. And again, our performance in 2021, although we're doing well, they are still considering COVID allowances for that calendar year performance. Next slide, please. And in district, we have somewhat of a cadence. Each year we report in April and in October. And so just so you can see where we are in the full district program, we started off on the far left in 2018, 2019, and we've reported each year and earning quite a good percentage, over 90% of our incentive available. And then so far this year, if you go over to the second to the last arrow, there's the 2021 column, and we have completed that first bullet. We reported our calendar year 2020 achievement in April of 2021. We should be receiving our payment in July, and then in October, we will report our category A. Our performance measurement will end this December 31st, 2021, and then our final report will be in April of 2022. And each year we have had the opportunity to carry forward measures that we didn't quite achieve 100% on into the next calendar year for performance. Unfortunately, for 2021, we do not have that carry forward opportunity. So our final time to perform, or our final measurement period for performance, will be December 31st, 2021. Next slide, please. And that's the end of the current situation or current status of the District 2 program, but I do want to go and highlight some projects for District 1. The first project, we had the disease management registry, and our FQHCs use the registry daily to identify care gaps for their patients. Some use the platform Eye to Eye, and then as Jason reminded us earlier, CUC has implemented Epic, and Epic actually has that capability built in. And so they're no longer using Eye to Eye because they're using the platform Epic. Chronic care management protocols were developed, and our FQHCs continue to use those protocols for standardizing care for conditions such as diabetes and hypertension. For the expanded primary care hours, Southeast Health and Wellness Center was built and opened in 2014, and that site it remains CUC's largest clinic. Expansion of dental services, we have expanded our capacity under district, and then in the last couple of years, we've also added Lone Star Circle of Care and People's Community Clinic as dental partners, and we are continuing to look at opportunities even into FY22 and further on to expand our dental capacity. Under the District 1 program, the FQHCs did achieve the highest level certification of the patient-centered medical home. For mobile health clinics, CUC purchased a mobile health vehicle, which was recommended by the district project team. And currently that provides services at the Creedmoor Community Center as well as Barbara Jordan Elementary. For the FY22 budget, we propose to expand our mobile and street medicine strategies. For system navigation, we incorporated care management and navigation services to primary care service agreements and developed central health hospital transition of care teams. Next slide, please. The Centering Pregnancy program continues at community care, as well as the pregnancy prevention and STD screening, treatment, and prevention. Actually, that one, the prevention, pregnancy, and STD screening, treatment, and prevention continues at all of our FQHCs, and they provide the long-acting removable contraceptives. Telepsychiatry and integrated behavioral health are incorporated into our primary care agreements, and those services are offered at our FQHC partner locations. We've also expanded pulmonology and gastroenterology capacity. CUCs provided over 1,500 pulmonology encounters in FY20, and they continue to provide hepatitis C virus treatments which was introduced through district. FIT tests have become the standard practice among our FQHCs to provide colorectal cancer screenings. GI consults continue to be utilized at community care to increase access to care. And then finally, hepatology services are available through our partnership with Dell Medical School. And that concludes my presentation on the district program. Thank you.
And Chair Greenberg, I'd just like to close us out. Thank you, Barbara. And I think her mastery of the subject matter really comes across quite clearly. But at a higher level, I just like to reflect that, DSRIP has been an incredible opportunity for our community. It inserted some opportunities to build capacity and improve care for our patients in a way that, I don't think we would be where we are today without the opportunity for our safety net system. It certainly hasn't been perfect. It's a very complex program. A lot of the rules are dictated by the state and what's negotiated with CMS, but it's really helped us in terms of building capacity and in building a competency for being a data-driven and performance improvement-driven safety net system. So as you heard from Barbara and I think from Jeff and Lisa earlier, this is the last year. And based on what we know today, the CCC and Central Health will likely not be eligible for the programs that follow. So that's unfortunate, and I think it is a challenge for us. As Jeff mentioned earlier, the DSRIP program is the predominant funding source for the CCC. We expect that last payment related to our performance in FY22. And as you all know, we use the proceeds that are based on our performance to fund other healthcare services. So our challenge is, transitioning from a program that is a temporary funding source, and I think to Manager Valadez's point earlier in the night, making sure that we're sustaining those efforts. And they largely have been sustained, and I think they largely will be sustained and evolved into our primary care service agreements, into our specialty care agreements, and just in how we approach our work as a healthcare district and with our partners. Thank you all for your time tonight.
Thank you so much. And, this is it's been a wonderful opportunity for us. And we have not just risen to the challenge, we have really just exceeded. When you look at what we, Central Health, and all of our partners, and again, Barbara, that theme of partners have been able to do, it's really amazing. It is a challenge in that it's ending, and those we have to then incorporate with our own funding the outcomes that have worked, but we've seen them with the mobile clinics and how we've been using them. Barbara, a shout out to you and to your team for the amazing work that you have done and the outcomes that you have achieved under very difficult circumstances with COVID. And thank you for all of your hard work. Thank you, everyone. Members, yes, a round of virtual applause. Members, any questions at this time? Not seeing any. Well, then thank you very much for your time. That is, I believe, the last item on our agenda this evening, except for Agenda item number 8, you will recall that agenda item 7 was removed because there was no content necessary tonight. So that takes us to agenda item number 8. Confirm the next regular board meeting date, time, and location. Managers, our next Central Health Board of Managers meeting is a short special called meeting scheduled for Wednesday, August 9th, 2021 at 5 p.m. at the Central Health offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702, and or remotely by video conference, depending on the status of the governor's disaster declaration and stay-at-home orders. At this time, I'm ready to accept a motion for adjournment. Manager Valadez?
I second.
Manager Valadez moves adjournment. Manager Bell seconds that motion and emotion. All in favor, say aye. Aye. Opposed, same sign. Any abstaining? Managers, staff, and the public, thank you so much for your time.
Thank
Bye-bye.
you.
Thank y'all.
Thank you.